Good afternoon, everybody. A warm welcome to our speakers and to you all who have joined us for this exclusive virtual summit today. I'm your host, HR Venkatesh. I'm the Director, Training and Research at Boom Live. We are fact checkers and we address misinformation. And we are honored to be collaborating with the Ananta Center for this, the Reimagining Healthcare Dialogues Summit. The theme of this summit is understanding India's healthcare needs and articulating our potential to build ventures that save lives and create value. And our panel of experts and thought leaders are here today, and they will help us get a multi-stakeholder perspective on the healthcare industry in a post-pandemic situation. And speaking of the pandemic, it's exposed, as we all know, deep structural data gaps in India. Epidemiologists and public health experts, for example, have found it challenging to build predictive models on healthcare responses and appropriate infrastructure as well for the future, even as civic authorities, on the other hand, have not been able to scale up resources and supply chains. Also, this including in areas like oxygen and high impact medicine. So the discussions today will focus on some of these key drivers that will contribute to the overall growth of India's healthcare industry. And now, just about a minute into our opening, I want to, and it's my pleasure to invite Ms. Indrani Bagchi, who's the CEO of the Ananta Center, to deliver the welcome note. It's over to you, Ms. Bagchi.
Thank you so much, Venkatesh. And good afternoon, everyone, and welcome to our inaugural healthcare summit called Reimagining Healthcare Dialogues. Thank you all for joining us, and I hope you will stay because we have put together Ananta Center and Boom Live. We have put together a fantastic group of speakers and panelists to keep you riveted for the next few hours. Today's discussions, we will strive to obtain a multi-stakeholder perspective on the healthcare industry in a post-pandemic situation. We would like to take this opportunity to understand India's healthcare needs a little better with the experience that we have gained over the last couple of years, with the opportunities that technology and other scientific tools offer us today, and just to articulate the sheer potential to build ventures that save lives and create value in the healthcare space in India. I would like very much to express my deep appreciation to all our speakers and our audience for joining us for this summit. We hope you will find as much value in it as we did and enjoy this as much as we did when we were picking out our speakers. And we actually have a very, very good lineup of speakers. I'm looking forward to this fascinating and insightful discussions today. With this, let me hand the floor back to Venkatesh. Thank you very much. And
thank you so much, Ms. Bagchi. It is exciting, the lineup of speakers, and let's just dive straight into our keynote. We have with us Dr. Gagandeep Kang. Many of you, almost all of you perhaps know all about Dr. Kang, and the address for the topic now is At War with Viruses, How Science Can Beat Viruses. And she's a professor in the Department of Gastrointestinal Sciences at the Christian Medical College, CMC as it's called, in Vellore, Tamil Nadu, India. She's the Vice Principal for Research and Head of the Wellcome Trust Research Laboratory at CMC. And Dr. Kang's research on pediatric diarrhea focuses on rotavirus epidemiology, prevention, and vaccine development. And for molecular strain surveillance, she's built her own work to develop a network of India-centric virology laboratories and the WHO rotavirus reference laboratory for CRO, all of which have resulted in insights into the epidemiology, burden, and transmission of rotaviruses in India. Dr. Kang, it's over to you.
Thank you very much. I'm going to be talking to you about how we use science to talk about viruses and what it is that we can do. I hope that you can see my slides. And I'm going to use as an example the virus that we've lived with for the last couple of years. and not really draw upon the work that I've done before this. As with practically every other virologist in the world, we've also been drawn into studying COVID-19, but today I'm not going to be talking about our own work. So if we look at science and viruses, everybody talks about how science brings us solutions, technology brings us solutions, but the solutions and the learning just keep coming. We've had some really exciting news in the past week because Moderna announced results from their bivalent booster candidates. So they looked at a vaccine, their original mRNA vaccine, which was made based on the older strain of the virus. And then they made a vaccine that was based on the beta strain of the virus. And in their announcements, as you can see here, they claim to have met the objectives that they had for their bivalent booster candidate. Now, just to show you the science behind this, this is what it is. What were they trying to do? They had an old version of the vaccine, which is called mRNA 1273. They also made a new version of the vaccine based on the beta strain, and they mixed the old and the new variants together, the mRNA for the variants together, to create a vaccine that they called mRNA 1273.211. So if you look at the top graph, I'm going to walk you through the first figure so that you get a sense of what we are talking about. So in the first column, what you see here is mRNA 1273, the original mRNA vaccine. And in the next, you have the mRNA 1273-211, 50 micrograms. What do you see here? These are people who had received 2 doses of the Moderna vaccine at least 8 to 9 months before. Their antibodies, their neutralizing antibody titers before they got a booster dose were just above 100 on average. And then after they were given another dose, a half dose, the old dose was 100 micrograms, they were given a half dose as a booster. This then went up at 4 weeks after immunization to over 1,000, 1952. And then at 6 months, it declined to 673. When you compare the old version and use the same 3 time points with the bivalent booster, what you see is you started at a similar sort of level, 150, 103. You boosted to about the same level, but you were able to maintain antibodies at a somewhat higher level with the bivalent boost than with the homologous boost or the same vaccine being given again. Now, this was for the ancestral SARS-CoV-2. Now, if we come down and look at beta over here, this is beta. And this vaccine consists of a mix of beta and the old version of the virus. What you see here again is that when you have the combination gives you better results than the ancestral version of the virus. Not only do you see results against the 2 viruses that are included in the vaccine, you also see a pretty good immune response. In Omicron, which is not related to the ancestral virus or the beta, and for Delta, these are lower than we saw for the ancestral strain or for the beta strain, but still pretty good. On average, anything above 100 that is sustained over time is considered pretty good. So if you look at these figures, what are they showing us? They are showing us that when you give a bivalent booster dose of the mRNA vaccine, you make antibodies that are better than antibodies if you use just one virus alone, and that these antibodies last for a reasonable length of time. In addition, you also see that the breadth of the immune response is higher because wherever you give the bivalent performs better than the ancestral way. So this is the science that we have this week. What does this mean for us? This means when we begin to think about booster doses, maybe we are talking about the next generation of vaccines. Is this the end of what we will learn? I don't think so. I think we are going to keep learning as we live with this virus and we continue to investigate what we can do with modifications of the virus and also what the virus is doing in humans and in populations. So let's go back now to January of 2020, where we had the first description of SARS-CoV-2, which, it's a virus, everybody knows that, and the virus has been described as a piece of bad news wrapped up in a protein many, many years ago. And if we are to study the virus, it's very important for us to have the genome of the virus, because when you have the genome, you can understand what structure is, what function is, and how to modify it. And this description that has been published in the New York Times is a great way of trying to understand what the virus does. This is a very large virus, 30,000 RNA letters in its genome. There are 16 proteins in the virus that don't actually make up the structure of the virus. There are only a few proteins, the S, E, M, and N proteins, which are structural. Everything else is actually functions that allow for the virus to replicate within cells. And for some of these proteins, we understand what the function is. For many others, we don't. NSP1, for example, suppresses an antiviral response. NSP4 creates the vacuoles within which the virus replicates. NSP12 is involved in the copying of the RNA of the virus in order to make proteins. NSP5 clips different parts of the genome that is being read so that you have sequences for proteins to be made. There are also many proteins for which we don't quite understand what the function is at the moment. So when we were at January 2020, what did we have? We had a number of scientific challenges. We had a lot of logistic challenges, but the first one was to know, did we have the right tools to be able to identify the virus? And if you think back to April of 2020, one of the biggest questions was ICMR made a recommendation of using antibody tests in order to be able to detect clusters of infection. And this was something that horrified the medical microbiology community because the tests were not very good, and using antibodies to diagnose clusters is not really the best epidemiological tool to have in an evolving situation. We are in a much better position now. We were able to use the sequence of the virus to create very rapidly RT-PCR tests. We were able then to develop antigen and good antibody tests. And we're now in a pretty comfortable position where diagnostics is concerned. We also had to begin to think about treatments. And for treatments, the first thing that you do is try and see if you have drugs that are already available that you could use. So chloroquine was an example of an available drug that at least theoretically could be used. You also think about new drugs. You can also think, in the case of viruses, we know that antibodies really matter. So could you use antibodies from people who had been infected, or could you develop new antibodies that could be used for people? And one of the remarkable things about this pandemic has been not just the amount of work and studies that were done, but the coming together of people to be able to use the right kinds of tools in order to evaluate treatments and vaccines. particularly the studies, the trials that are called Recovery and Solidarity, are the scale of trial that has never been done before. It's actually advanced clinical trial science because we've had adaptive trial designs, where if one treatment is not working, you can take it out and replace it with another treatment. So we've done a lot of work, both in terms of preclinical as well as in clinical evaluations, to be able to come up with drugs. We also had challenges in vaccines where we had untested platforms. We were trying to work at a speed and a scale that had never been done before, with partnerships that between regulators, the government, companies, academics, that had also never been done at this scale before. And of course, regulators had to interact with each other and with WHO to try and figure out how to get vaccines to us that was safe, effective, but also rapidly available. Now, it's important to remember that all of the work that we've done in the last 2 years actually builds on work that had happened for many, many years before that. We've actually known human coronaviruses, and the ones that were in humans before 2000 were the coronaviruses that generally cause mild upper respiratory infection. But in 2003 and subsequently, we've had coronaviruses that caused serious disease. SARS-CoV-1, as it's now known, as well as MERS coronavirus, taught us a lot about infections that we were able to use during this pandemic. What we did know from SARS-CoV-1, and I'm not going to walk you through this entire figure, but just to say that we understood that viruses needed to have receptors that allowed them to get into cells, that once viruses got into cells, their message had to be read to make a number of proteins at different locations within the cell, and then the fully formed new viruses have to be released. Now, this is a process that is followed for all viruses. And the advantage of having an understanding of the replication of a virus is this allows you to identify spots for intervention. So the more you know, the more you can think about where are the points where I can interrupt the replication of the virus. Now, of course, the first thing would be, can we stop the virus from getting in? And from the previous coronavirus studies that had been done, it was very quickly possible for us to think about how SARS-CoV-2 replicated as well. The ACE2 receptor had been identified for SARS-CoV-1, but there was a second receptor, which is called TMPRSS2, which was being used by SARS-CoV-2. And the way this worked was that you have a spike protein that binds to the receptor, you cut off the top of the spike and bring the virus and the cell close together. They fuse with each other, and then the virus sends its message into the cell. This whole process takes about 10 minutes. So if you have to interrupt any of this happening, you have to be able to be present before the virus even gets in. And sometimes this is what you can do with preformed antibodies. But there is more than one entrance mechanism. So if you want to block viruses, you actually have to block all the ways that the virus can get in. And I had mentioned chloroquine previously, so I think it's important to point out that chloroquine actually blocks endosomal fusion, which is one of the ways in which viruses can get into cells. Now, Omicron actually uses endosomal entry and is not TMPRSS2 dependent. So the question arises, if we used Omicron, if we were studying Omicron infections, if that had happened before all of the other variants we saw, would chloroquine as a treatment have worked? Well, those trials are no longer being done now, but we do know that chloroquine didn't work for the older versions of the virus that we had. So if we think about therapeutics, we can also think about, where else can interruption happen? And one of the things that is being very widely used is a variety of monoclonal antibodies that try to prevent the virus from getting into a cell. And as we've seen with Omicron, most of the monoclonals that we had stopped working. So what had worked well against Delta, shown here in blue, did not work against Omicron, which is shown here in red. There was one monoclonal antibody, Sovitramab, that worked, but that worked only for BA1 and didn't work for BA2. So understanding what you're dealing with and what treatments need to be applied at what times in which patients requires a deep understanding of what is happening. So therapeutics, understanding, as I mentioned, structure, function, replication, allows us to then develop a variety of new drugs. And molnupiravir and Paxlovid have all been developed based on a deep understanding of how the viruses replicate. Steroids, similarly, we now know that steroids work by reducing a hyperimmune response. This is also the reason why you have IL-6 that is involved in the generation of an inflammatory response. Many of the drugs that target IL-6 can also be used in SARS-CoV-2 for this reason. Now, when we come to vaccines, a deep understanding of viruses becomes even more important. Earlier work on MERS and SARS had shown that in the spike protein, where we understand the structure, we needed to have a stabilization of the spike protein in order to induce the right kinds of neutralizing antibodies. And this data built on work that had been done looking at respiratory syncytial viruses, not just, so we had work on HIV, RSV built on the HIV research, and then SARS-CoV built on the RSV research, and SARS-CoV-2 and MERS built on the SARS-CoV-1 research. So this proline stabilization has been used in multiple vaccines in Moderna, Pfizer, Novavax, and Johnson. And now we are developing a sixth proline stabilization that might be even better than the vaccines that we have at the moment. We also need to understand how the antibodies work. There are 4 classes of antibodies that are responsible for neutralization of the binding between the virus and the ACE2 receptor. And then depending on which one you have, they can be highly potent, but they will also be in the regions that are most targeted by mutations when we have variants of concern arising. So there are advantages and disadvantages to making different kinds of monoclonal antibodies. All of this understanding of structure and replication allows us to understand what the best points of intervention really are. And understanding sequence data also tells us a lot about the variants that can arise, why they arise, and why it might be very difficult for us to get rid of this virus. We know that this virus can spread across species, and that makes elimination or eradication of this virus very challenging because you've got a number of host species in which this virus can go and hide and then evolve through combination with human coronaviruses. Now we have data that has been generated from sequences, from the lab, etc. But I think ultimately data has to come from humans. And it is the ability to do studies that are in cohorts. What this shows you is essentially what happens in terms of neutralization in people that are infected with different kinds of viruses. And essentially, all this figure is showing you is that Omicron, which is shown here in black, it doesn't matter what kind of infection you've had previously, Omicron could not necessarily be blocked easily by pre-existing antibodies. A fact that was available in lab studies early on using samples from humans that was then validated in the epidemiological information that we had. So to end, we had some exciting news in the past week, but with science, there's always exciting news because there are always questions that remain to be answered. Just for SARS-CoV-2, what about cellular immunity? How long should you take for boosters? What about long COVID? When you have drugs, when will antiviral resistance come? What really are the best combinations that we should be thinking about? There is no end to the questions, but I think together, what we have shown in the past 2 years is that we can answer a lot of questions really fast, and I hope that we will continue to do so. Thank you.
Thank you so much, Dr. Kang. We have a couple of questions. I wonder if you would be willing to take them. Just for those who, before that, just for those who have just joined in, there was an extremely enlightening keynote from Dr. Kang. She explained to us how the work that Dr. Kang and others around the world have done in the last 2 years impacts what is going to come after, and what we've learned from the vaccine, what we've learned from how the vaccine has worked among people, what we are continuing to learn. That was extremely enlightening. And Dr. Kang, I just want to just take a question. Someone who refers to themselves as anonymous has asked a question which I think you mostly answered, which is, since when SARS-CoV-2 has been with us? Because I hear it was there before as well. You did show us that slide showing that it's been there for more than 50 years. But I will take the opportunity to kind of reframe that question a little bit. Does the scientific community at this point in time worry at all about what the origin is of this virus? Because that is also the question that this person has asked. Or is it something that you're saying, okay, this is a fact of life, and let's focus on what we can control? What's the approach like?
Okay, so let's look at it this way. Is SARS-CoV-2 a new virus? Yes, it is. Does it have relatives? Yes, it does. Which is its closest relative? It's SARS-CoV-1, which we had in 2002, 2003. Could this virus have been made in a lab? Sure, it's feasible. Could this virus have evolved naturally? Sure, that's feasible too. The closest relative we have for this virus is actually a virus from bats in the mid-1980s, where it was hiding away during this time. Whether it was being experimented on or was evolving naturally is not something that we can answer with the data that we have.
Right. Just a couple of more questions are there. And this is a Reimagining Healthcare Summit. But obviously, the audience, we're all experts here, but we're also people who have suffered through the pandemic. So there are some sort of basic questions which I'm going to take the opportunity to ask you. Someone asks, are all viruses bad for us humans?
Some viruses are actually an advantage for humans. So in fact, when you have an antibiotic-resistant infections, one of the new and very old treatments that people are trying out is viruses that infect the antibiotic-resistant bacteria. Those viruses are called bacteriophages because they eat up bacteria. So viruses can be beneficial as well as being harmful.
Correct. And that in fact was a question by Dr. Fuad Halim. And there's one last question, Dr. Kang. Someone is asking you to explain, and I don't want to kind of interpret that question. So I'm just going to read it as it is.
I've seen the question in the chat box, so I'll answer that. Okay, so with any vaccine and any drug, I think it's important to understand that nothing is perfect in this world, right? So with every vaccine, with every drug, you don't expect 100% efficacy and you don't expect 100% safety. With many existing vaccines, we know of side effects. There are common side effects, which is the pain, the swelling, the fever that you get when you get a shot. There are also rare side effects, and the rare side effects can vary quite a lot. Guillain-Barré syndrome has been associated, it's a paralysis, has been associated with some influenza vaccines. And with the AstraZeneca vaccine and the Johnson & Johnson vaccine, we have had a special condition that is called TTS, thrombosis with thrombocytopenia syndrome, which is the formation of blood clots and a reduction in the platelet count. This is a very rare side effect. In places where it has been described as a rate, the rate has been a maximum of 1 in 40,000 vaccinated people and as low as 1 in 2 million people. This is associated with the viral vectored vaccines. The way you can look for it is to look for the occurrence of a blood clot as well as a reduction in the platelet count and the presence of an antibody called antiplatelet factor 4. If these occur between 4 and 20 days after a dose of the viral vector vaccine, it is likely to be associated with the vaccination. This is a rare side effect. It is known. Our AEFI system in India is a 3-tiered AEFI system, but has picked up very, very few cases of VITT or TTS. Most of the data that we have on this condition comes from high-income countries.
Okay, that was enlightening. And just a reminder for those of you who want to listen back, the recording is on. It'll be available on YouTube as well. On that note, thank you so much, Dr. Kang, and thanks for taking those questions as well. There's plenty to come in the summit, exciting conversations, but this was a great start. Thanks. Right. So let's move to the first panel of the afternoon, and this is on learnings from big data from the pandemic. And our moderator for this panel is Dr. Ajay Nair, the CEO of Swasth Alliance, a non-profit health collective that builds digital health infrastructure and standards for public good. He's been an advisor to digital health innovators, advisor to non-profits, governments. After this is co-founding and leading one of India's first telemedicine networks called Mera Doctor. And prior to this startup journey, he was a social impact investor as well at Acumen Fund in New York and Nairobi, focusing on health and energy. And as a doctor, he's also helped set up and run HIV or STD clinics for male and female sex workers in Mumbai. He has an MBBS from Grant College, Medical College, and an MPH from Harvard University. He's a fellow of the 7th class of the Kamal Nayan Bajaj Fellowship within the Aspen Global Leadership Network. On that note, it's over to you, Dr. Nair, and I know that you'll be introducing your panelists.
Thank you so much, and thank you everyone for joining this session. And thank you for joining this special panel on big health data learnings from the pandemic, functioning disease surveillance system. Data has various uses in the public health context and comes from a very wide variety of sources. It could be population surveys, registration of vital events, disease surveillance and notification system, routine reporting from health services, or real-world data. There's also new kinds of aggregate data that we've seen being used in the pandemic. We've seen mobility data from telecom companies, platform providers like Apple and Google. And this data has various uses beyond early warning and pandemic management, from drug discovery and development to improve targeting of health and social inequities. And we've all heard this cliche about data being the new oil or the new gold. But we've also just heard Dr. Kang say that most of the data we rely on in India for decision-making actually comes from high-income countries. So the questions, we need to ask ourselves is not just, what does the data say, but also the question is, how has data helped us so far in the last 2.5, 3 years of the pandemic? What have we learned about how to collect and use data? And how does data lead to evidence and decision-making? And so with that, let me just quickly introduce this very eminent panel that we have here. I'm going to step back and take a passive role and let the panelists speak for themselves. I'll very quickly introduce the panelists, and then we'll have a free-flowing session. Please keep your questions coming in the chat box. We'll try and pick them up as quickly as we can. So on to the panelists, we have with us Dr. Professor Manendra Agarwal, who is the head of Department of Computer Science and Engineering at IIT Kanpur. Professor Agarwal has made significant contributions to the theory of efficient reactions between computational problems, which are part of the problem studying the well-known P versus NP question in mathematics and computer science. He co-created the AKS primality test with Neeraj Kanyal and Nitin Saxena, for which he and his co-authors won the 2006 Fulkerson Prize and the 2006 Godel Prize. He was also awarded the Clay Research Award for his work in 2002. Welcome, Dr. Agarwal. Joining us next is Dr. Chandrakant Laharia, who is a medical doctor, vaccines, public policy, and health systems expert. For 13 years, he coordinated the World Health Organization's work in India on new vaccine introduction, routine immunization, health system strengthening, and universal health coverage. He has done extensive work on India's COVID-19 pandemic preparedness and response, including the COVID-19 vaccination rollout all India. Welcome, Dr. Laharia. Our third speaker is Gautam Menon, Professor of Physics and Biology at Ashoka University. Prior to joining Ashoka, he was a professor at the Institute of Mathematical Sciences in Chennai. He completed a BSc Honours in Physics at St. Stephen's College in Delhi, an MSc from IIT Kanpur, and a PhD from the Indian Institute of Science, Bangalore. Following postdoctoral work in Mumbai and Vancouver, he joined the Indian Institute of Mathematical Sciences. He works on a number of biophysical problems, including nuclear architecture, axonal transport, collective cell migration, and cell adhesion, all in the general field of mechanobiology. The modeling of infectious diseases and its implications for public policy is a long-standing interest of his, while the use of machine learning methods in clinical context is a recent one. And welcome, Professor Menon. Our fourth and final speaker for the panel is Dr. Tanu Singhal, who is a consultant pediatrics and infectious disease at the Kuklaben Dhirubhai Ambani Hospital and Medical Research Center in Mumbai. Dr. Singhal has been associated with the Kuklaben Hospital since inception in 2009 as a consultant in pediatrics and infectious disease. She received training in pediatrics at the All India Institute of Medical Sciences in Delhi and in infectious disease and international health, the London School of Hygiene and Tropical Medicine in the UK. She acquired further expertise in pediatrics and infectious disease at Hinduja Hospital in Mumbai. She has to accredit 2 books, 20 book chapters, 65 publications in indexed national and international journals, and several hundred guest lectures. Dr. Singhal is an advisor to the ICMR on antimicrobial stewardship, a technical expert in pediatric tuberculosis for the National Tuberculosis Control and Elimination Program, and also an executive board member of the Fungal Infection Study Forum. So with that, welcome, Dr. Singhal. So as I mentioned earlier, I'll step back and I'll let the panelists speak. I'm sure we'll have a very exciting discussion. I had a quick chat with the panelists before, and what we talked about was if they could walk us through their journey over the last 2.5 years as it relates to data and health. They are all either prominent consumers or creators of health data. And talk about their journey and then talk about the learnings. We'll also briefly touch upon this controversy around the methodology for measuring the death counts in India, probably at the end of the session. So I'd like to start with Dr. Agarwal, and I know, sir, you have some slides. Go ahead, please.
Thank you. I'm going to share a few slides on data and the COVID pandemic. First of all, thank you for having me on this panel. It's a very topical one and very interesting one as to how data can and has influenced our understanding of the pandemic. So the approach I'm going to take is that how the data that we have received, how that has helped in our understanding of the pandemic. And second, what more data, had it been available, would have made things even better. Let's start with what was available and what was its use. So if you look at availability of data, there is something remarkable that happened this time. Across the countries, we had daily new infection and death time series available. This, I don't think, has ever happened in the past. Probably 100 plus countries were every day reporting new infections and deaths. And when you come to India, of course, we had this data not only for India, but at the state level, all states were reporting this. And if you go down further at the district level, most of the districts were also reporting. And our estimate, 70+% of district did report in certain way the new infections and deaths. So that's a huge data and very interesting data. What use can we make of it? Here is an example. This is a study we did using our Sutra model. And the topic of study was, how has Omicron mutant caused immunity loss? So there are two types of immunity that here we are talking about: vaccine-induced immunity and natural immunity acquired through a past infection. So what we did was, we took 27 countries, which represent about half of the world's population. And we had to cut out many countries. For example, countries following zero COVID policy or placing too many restrictions were not amenable to such a study. So we picked up more populous countries with a significant population, which had satisfied the certain requirements that we had. And if you see this plot, this is a plot on the y-axis you can take roughly the loss of immunity that has happened in percentage terms. And in the x-axis is what were the percentage of vaccine-only immunity in that country. And you see quite a remarkable match here. It's a direct correlation between the loss of immunity and the amount of vaccine-only immunity, with a very high R-square value of the fit. So what this tells us is that the vaccine immunity was quite significantly bypassed by Omicron. Of course, it has been confirmed by certain other studies as well, but this is a data which you can take across the country that provides a very good picture of what has happened. Even more remarkable is the next study, which plots loss of immunity against natural immunity present in the country. And here the picture is totally inverted. There is a very strong negative correlation between the two. And again, a very good fit of basically telling us that the higher the natural immunity in that country, lower was the loss of immunity. So what we can draw conclusion from this is the vaccine immunity was more or less bypassed by the Omicron. Now, of course, here I don't mean that vaccines are useless. Vaccines did protect and continue to protect against serious infection. But here, what I'm focusing on is ability to infect. So vaccine against Omicron were not able to stop infection. On the other hand, natural immunity was very good at stopping even infection by Omicron. And that is shown by this study of data across the countries. So that's kind of information you can extract if you have this kind of data available. Now, coming to the quality of data, there has been a lot of discussion around that as well. We had a look at the Indian data and compared the data with other countries, and we found that Indian data reporting is better than most of the countries. Just to give you an example, here is a UK data. The entire timeline of daily new infections averaged over 7 day weekly period, so that weekly variations are smoothened out. And you can still see a lot of jagging up and down. It's small, perturbations. And then there is a big stuff here. Even if you ignore that, there is quite a bit of jitter in this data. Look at the US. Again, less jitter, but still the jitter is present all across the timeline. Compare this against India. Much smoother data. There is some jitter, yes, but it's a lot smoother compared to the US and UK data. So what this tells us is that in the reporting of data in India was a lot better. Whatever the strategy or policy was being followed to report data, it was very consistent and implemented across the time in the same way. So that's another thing that you can learn by just looking at the data which is available. Now coming to what are the limitations of that we have seen. District level data, if you look at India, it required very significant effort to extract. When I say that 70+% districts reported data, it was not a very simple reporting. In fact, the volunteers in COVID19.org spent uncountable hours in trying to extract and collate and make sense of that data. And since they stopped working, and then a lot of district data stopped coming. More than that, many states never even bothered to report district level data. Andhra Pradesh is one example. So that's been a drawback. And if we have this full data available, what we can do is we can actually study how the mutant, either Delta or Omicron, has spread from district to district across the country over the timeline. We are still doing that study, but it will be limited to the districts for which we have it. Mortality data that was already alluded to, and there is a lot of controversy around it. A huge uncertainty about it. What was the actual number of deaths? One thing is clear: whatever is the reported number of deaths, the actual number of deaths was higher than that. The debate is around how much higher. It has led to a number of studies, and I have had a chance to look at many of them, and I found that a number of them have made very questionable assumptions to derive certain conclusions. But this is bound to happen if you don't have data on it. And this is where I think if CRS data was available, even for 2020, we do not have CRS data till date formally. So if CRS data was available timely, a lot of these controversies would have been simply avoided. Using that, one can arrive at a fairly good conclusion as to what would be the estimated number of deaths due to COVID. So that's the kind of role that data can play. The availability of data can really make a difference, can inform the policy, can avoid controversy. So I am all for reporting as much data as quickly as possible. Thank you.
Thank you, Dr. Vimal. I'd like to move on to the next panelist, and we can then maybe open up a discussion on some of these points that you brought up. But Professor Menon, do you want to come in next?
Sure, I can do that. So thank you, Ajay, for this invitation, and thanks to Boom for this request to speak here. So we've been involved in modeling COVID-19 in India pretty much since the beginning. And this grew out of an initiative called the Indian Scientist Response to COVID-19, or the ISRC, where we assembled a group of people with some modeling expertise across various different areas, including epidemiology, to try and construct what we thought would be a good model for India to ask us out of questions that we wanted to ask of India. In fact, compute, for example, mortality, numbers of hospitalizations, the number of cases requiring ICU usage, etc. But also to use these models in other ways to try and understand what might be good policy. So the sort of question that we were looking at early on is not just trying to understand the trajectory of cases within India with reasonable numbers that we had, not from India at that time, in fact, not from India for a very long time and even now, but as Professor Kang said, numbers from the West, from China, from Italy, etc., which feed into our models. These are fairly detailed models. So they, for example, they will tell you what is the likelihood that someone between the ages of 20 to 30 who contracts COVID will have a serious infection that will require hospitalization or not, whether they will die or not. So all of these factor in. So you need to know what, for example, is the infection fatality ratio as a function of age or age bracket. All of these numbers go in the description of the demographics of the population, the age distributions, etc., which you use to make more and more granular estimates for different states, for different cities, etc., to how they might be, to how the pandemic might unfold there. So among this, as I said, we're also interested in questions a little away from data and a little towards policy itself. What's the right way to open up? If you wanted to open up, would you stagger up openings? These were questions that were important at the end of the lockdown, of the first lockdown. In fact, the sequence of lockdowns of almost 70 days that we had. So the questions were, when you opened up, should you have opened up altogether? Should you open up in a staggered manner with just 50% of the population? Should you open up all of offices together or reduce that? Should schools be opened, etc.? So all of these are difficult questions which we try to address using modeling methods. And that's where I think models really are useful. It's not really a sort of tracking trajectories on a daily basis, because those numbers are genuinely not very good. So here I would differ from views that say that Indian numbers are good, et cetera, compared to other countries, because I don't think that is true. Even now we are seeing cases where Kerala, for example, is adding deaths, backlog of deaths that it was asked to recount to the current number. So these numbers are shifting even as we speak on a day-to-day basis. We know the discrepancy between real cases in terms of serological studies, which look at the amount of antibodies that you have against SARS-CoV-2. Compare that to the number of cases that have been officially recorded as far as the part of testing. In some states, this is the deviation between these numbers is a factor of 100. So for every case that you record, there are 100 cases that you're actually missing. So that makes a mockery of any type of a way of understanding data and predicting the curves of data, because just you'd have no access to the right numbers. And the distinction between the right numbers and the number that you record is actually very large. So on this basis, you can say, have states done a better or a worse job of recording numbers? That you can certainly do. And certainly one way of doing it is to look at the discrepancy between a serological study and a study that you get from just looking at official case numbers. This is nuanced, of course, in many ways. We don't really have an understanding based on really large data of how many people are being reinfected. We can make guesses. What are levels of reinfection? What do they depend upon? If you have a prior, if you were infected with a Delta or the original variant or something later, what are the chances that you will be reinfected by Omicron? What is the relative seriousness of the case of your clinical presentation? All of these are numbers that we need to actually add in. So among, I think, the interesting things that we've done from the modeling angle are questions like, when is the right time to open schools? So here we work on fairly complicated models that try to reproduce the structures of families that surround a community surrounding a school. So a community of catchment area of about 20,000 people who feed in children to the school. So you imagine families who go to work and come back, children go to school and come back. You have teachers in the schools who go there and can transmit the infection. And you assume at a certain background level of disease that's already infected the population, when is it safe to open schools? So you can compare a situation where the school is closed with a situation where the school is open and say, do cases go up? How many hospitalizations do you expect, etc. So this really then becomes useful for policy, because then you can say that this state with a seroprevalence of 60% can open schools with no problem at all, whereas another state with a seroprevalence of 35% should consider whether this is the right time. And also make very specific suggestions. For example, vaccinate the family members of school-going children on priority, because the children have not been vaccinated. They will go to school and come back, and they act as efficient vectors to transmit the disease across to the whole community. That's one way of understanding how models can be useful to making very definite policy statements and nuancing them in the right way and understanding what are the trade-offs in a particular course of action. The second thing we did was an interesting question of how do you combine rapid antigen tests with PCR tests? What's the right ratio? Should you do only PCR tests, or can you combine PCR with rapid antigens? Of course, there's an economic perspective here. The rapid antigen test is a cheaper test than the PCR test. It's also a point of care test. You get a result in 15 minutes, whereas with the PCR, typically waiting can go between 24 hours to something like 36 hours, especially at the peak of the Delta wave, when you would recover before your test results actually came in. That's again a question where good models can help policy. And our finding there was that if you tested enough, if you tested at scale, you really needn't worry about having an all RAT regimen. And you really needn't have worried about this whole debate of you're doing too many RATs compared to PCRs. That wasn't necessary. So this is again where, as I said, you can nuance policy and policy understanding by using better model and input from data. Last question that you sort of talked about is, of course, questions around the WHO and undercounting. And I have no doubt that we'll come back to that question again. It's an important question. But there are certainly reasons to believe that we have severely undercounted deaths. I don't think there is any. If you wanted to argue against that, let me put the argument in this way. You would have to say that Indians are special in some way, that there is some Indian exceptionalism or South Asian exceptionalism in some way that should operate. If you take the numbers that we know, the numbers that represent populations across the world, and here the crucial thing, exactly as Gagandeep Khan pointed out in the earlier session, is that this is a novel virus. Nobody has any prior immunity. So there's no question of earlier coronaviruses giving you any special advantage or special exposure that might predispose you to a milder outcome. That's the essence of having something that jumps over, that spills over from an animal host into a human host. The human has no experience of it whatsoever. So there's no a priori reason to assume the Brazilians or the Americans or Europeans or Japanese or Chinese or Indians are in any way different from that point of view. They may have different distributions of ages across the population, but that we can factor into our models. If you assume that understanding is correct, then you invariably will wind up with numbers of deaths that are at least 5 to 6, if not 8 times larger than the current reported number. That's a simple fact of epidemiology. And it's hard to argue against that, as I said, unless you say that Indians are exceptional in some way. We can argue about the nitty-gritty of how the calculations are done, and certainly there are points of disagreement there, and they could have certainly been improved, but that's the essence of science. There is a back and forth that's required, and we improve our understanding, and we contradict, we challenge what is said. But finally, to say that we should not have this discussion because we have done better than other countries is something that we should not be doing. We should be honest and scientific about the way we approach it. So that's all I had to say, Ajay. Pass it on.
Thank you, Professor Menon. This is a good point to bring in the epidemiologist on the panel, Dr. Laharia. Would love for you to pick up here, maybe share a little bit about your work over the last 2.5 years as it relates to data and some of the lessons. And please do comment on the methodology with questions that we've been discussing.
Thank you very much. So when you are in a pandemic, you need a lot of data to make inferences and to provide solutions. So what we are hearing that there was a lot of good data from India. Of course, on some matters, there was reasonable amount of data and it improved over a period of time. But let me start with what Professor Manindra Agrawal said, that smooth curve. What we need to remember that, of course, India had some of the good data on testing because that curve report the daily COVID-19 test confirmed cases. And in some period of time, especially when there is a risk of that curve being different, there was those laboratories were functioning to the optimal capacity. So there was no buffer capacity to go beyond. So they were doing whatever could be done. That is my answer to that approach. But of course, we had data on daily reported cases and whatever data there is there. Professor Menon also reflected about that. What we know that India has its own data, but we also know that in successive sero survey, we know the number of infections were at least 30-fold higher at the national level than officially reported numbers. And now this scenario did not alter over a period of time. Like there are 4 nationwide sero survey, and in all sero survey, we found that officially reported cases to the infection ratio based upon sero prevalence was somewhere close to 30. And what it reflects that even though capacity increased, our reporting of that data did not change. So of course, we cannot say in that setting that we were doing very good job. But having said that aside, there is another dimension which I want to bring in. That even when the data was available, COVID-19 cases, deaths, but we did not have enough granularity or breakup of that data by age, gender, distribution. It might be available in the public government, but it was not available for in the public domain for any outside expert to infer. And one of the big challenges, I just want to give an example for that, like Professor Menon already highlighted about school-related issue, but for example, immediately or in between the second wave, there was a lot of discourse that third wave would affect children. Now, it was very difficult to counter that argument because there was no data available in the public domain from the government that what proportion of children are getting affected. Then, of course, there was some data which is released by the government saying that this at 10% or so is the proportion of children of total infected, but there was no linkage of that data with the severity of the outcome. So infection is one thing, but how many of those were getting admitted? So in absence of that kind of data, detailed data, granularity, it was really difficult to make inferences. And impact was that it was challenging to counter or speak about it, whether children would be affected in subsequent wave or not, because there was no data, and even government took its own good time in responding to that. So there has been a practical challenges or implications of insufficient data in the public domain. I was also involved in one of the study where some of the researchers at Stanford University, that study is out a few days ago, in PLOS Global Public Health, we looked at 3 parts, like surveillance, vaccine coverage, and mortality. And we looked at how different Indian states are reporting, what kind of granular data is available. And we found many gaps and a lot of variations between the states in reporting of the data, including on adverse event following immunization, including which AEFI is happening with which vaccine, age groups. In fact, we also found during that analysis that many of the states also reveal the privacy-related information, personal information of individual in the public domain. So India's COVID-19 data definitely has many of the challenges. It has scope for improvement. Of course, one of the things we need to remember that how far we have gone or moved in this direction. We always knew, even before the pandemic, that health data is really not sufficient, not timely, or often incomplete. We know India's health information system, especially the National Health Profile, which is published by Ministry of Health and Family Welfare, Directorate General of Health Services. The numbers on various diseases keep similar for year after year. We also know that those numbers, like the reports from the field facility, do not reach on the time, including on the mortality data, that medical certification of causes of deaths in India at the national level is around 20% of the total deaths are medically certified. So these challenges have been there, and those challenges were amplified during the COVID-19 pandemic. It is very difficult for me to comment, and though I want to say something about it, but it's very difficult for me to, because the data was not available in public domain. So it's very challenging to say whether it has improved anymore or not. I hope that the systems have been created. Of course, we have a little improved data, more timely data, and government asked different state government to send timely data. We heard a few days back when Kerala reported a backlog of cases. Essentially, what Kerala did, because this incident also highlight the challenge of incomplete or non-timely reporting of data. Kerala had a 5-day of backlog in the data, and it reported 1 day. What happened that day? Because of cumulative reporting in day, the number of cases gone up from 1,000 that day to a 2,190% increase, so to say. It really created a panic because every single public person is not going to go and check that why it has increased. So even central government had written to Kerala government saying the report data in the timely manner. So this particular incident highlight why we should improve the data recording and reporting system, why it should be timely. And since this happened a few days ago, 2 years and 25 months into the pandemic, it shows that we still have a long way to go. I also want to flag another important issue that many of the researchers, almost every public health person or many of the people who are involved in pandemic are continuously raising the issue that the government should be providing that kind of information where the COVID-19 confirmed cases and then their variant, their clinical outcomes needs to be linked. And that is a kind of next step we need to move on. And I'm not sure, and somebody might be having access to that kind of data, but definitely that kind of data and linkage of the data is not available in the public. I would like to close with the 2 points. One, on the mortality statistics, mortality data for India, I think I agree with everything Professor Menon has said. What is given, that absolute number of the actual mortality in every setting, no matter which part of the world, be it India, UK, Europe, United States, would be higher than officially reported number. The only question is that whether by how many fold. In UK, USA, it might be 1.6 or 2-fold, but in India, it definitely would be higher than what the number for other better reporting mortality systems are. So it's given that India's actual number would be higher, and of course we can debate, but we should accept any number coming, acknowledging that there are methodological challenges. But I would not say that we would outrightly reject those numbers. And final point I would like to make, okay, we should analyze these challenges that data is not available in timely, transparent, or manner in public domain. But bigger question is that, are we going to learn from this pandemic challenge? Are we going to work to strengthen health information system or data recording reporting system for general healthcare services in the months and year ahead? And that is the moot point. Thank you very much.
Thank you so much, Dr. Laria. I'll now go on to Dr. Singhal. And Dr. Singhal, you as a clinician have been a consumer of a lot of this data and analysis, taking decisions that affect people's lives directly. Would love to hear about your experience with data, the lack thereof, and how the last 2.5 years have been for you.
Thank you, and thanks to Boom for inviting me for this nice discussion. So yes, we are consumers of data, but we are at also a very small unit which is generating data for the country, because we are reporting the number of cases that we have diagnosed in our lab, and we are also reporting deaths. So I just want to tell you where are the shortfalls, because we agree that there is a shortfall. So in terms of detection of cases, the reason there is this large gap between the number of cases and number of reporting is because, one, many people actually don't test themselves, especially if they have mild disease. Then also because, once one family member is infected and the other people have the same illness, they feel that they have COVID and they don't go and test. Third, the tests can be false negative. And fourth, many people actually in the beginning of the pandemic tested themselves late when the false negativity is high. And finally, also in the time of the Omicron wave, a lot of tests were done by the rapid antigen test, which were not reported. So that is also, we probably underestimated the number of cases which were happening. Besides, they were, although our labs really geared up to the occasion, but there were times when, I'm sure in remote areas, in villages, the testing facilities were not that good. So that is why you have this kind of shortfall. Now, in terms of reporting of deaths, because we also have been reporting deaths in our hospital, there is a challenge there. We know that the number of deaths which are underestimated are because of many people who die at home or who do not reach hospitals, especially in the second wave. But it is also to do with some other things. So, for example, if a patient has COVID and the patient has been in the ICU for about 2 weeks and then is moved out to a non-COVID area, and then he finally succumbs a month later because of some infection, that is actually not counted as a COVID death. So it doesn't figure in the statistics. And we in large cities have a lot of patients who have died in this way. And also sometimes, you have a patient, like it happened during the Omicron wave, that you have a patient who has, let's say, a myocardial infarction. And because there is this policy that, when a patient gets admitted to the hospital, a COVID test is done mandatorily and he turns COVID positive, though the COVID may have nothing to do with his disease, it will be counted as a COVID death. So there are issues regarding reporting as well. So I think that these are some of the reasons why apart from the other logistic issues, these are some of the reasons why you have this kind of gap. But, but at least as a clinician, we find a change in the COVID times, because we have never actually seen data coming in so regularly from the government ever for any other disease. So that data which came in about the number of cases helped us to plan our facilities, how many beds we need to increase. Also, it helped us to benchmark how are we doing compared to other places. So that is how that data helped, even though it has its limitations. I would now move on to an important point about clinicians. Our challenge was more about treating patients, and the data which came out in scientific journals about the treatment modalities, etc., was not up to the mark. And I think everybody knows it, because, finally we are doing it for treating patients, and this is a new disease. So when these first patients walked in, we really needed to know, how are we going to treat them? And you can see that there were so many drugs, because even scientific journals fast-tracked their articles, even MedRiv, anybody could publish anything on the preprint server, which would come into the public domain. And many of these articles were shared by WhatsApp. These were not peer-reviewed papers. And most clinicians do not have the ability to really judge whether what an article is reporting is correct or not. And that is the reason why, so many drugs, like, for example, hydroxychloroquine, azithromycin, ivermectin, doxycycline have been widely misused during the pandemic. And, when because everybody was clutching at straws, what can we do to help these patients? And we can remember that, initially there was a paper which said, okay, it may work. And then when other papers came which say that these things don't work, nobody looked at those papers. The kind of trend continued. I mean, the amount of azithromycin, doxy, and ivermectin we have used will cause so much of collateral damage merely because of these publications, which happened. Then we should look at the corticosteroid thing, because what happened is that in June, the recovery trial results came out that corticosteroids are useful in treatment of COVID. And I would compliment that the ICMR did come out with regular publications and telling people how they should be handling these cases. But then it is wrong on the part of physicians, but that this data did come out and it was in peer-reviewed journals, but nobody actually read the fine print about when they should be used, how much they should be used, when they should be stopped. And that led to actually so many deaths because of COVID-associated mucormycosis or the black fungus infection. So even in remdesivir, there was this flip-flop. Even for many other drug therapies, and actually, if you put COVID on PubMed, you find that there are already 250,000 publications. So it is that much of data is available in the public domain, and it is very difficult for clinicians to really sift through and judge what they should do best for their patients. And another infodemic which has happened is that the lay people also know so much about COVID, as unlike other diseases, because of WhatsApp call, etc. So that when a patient comes to the hospital and gets admitted, he already has information about drug therapies, and they also argue. They may not know. So we also were facing this kind of infodemic, which we had to grapple with. So I mean, we looked at all the other data which came in, but our concern was mainly data which was being published in scientific journals, and how to interpret that and how to treat our patients to the best of our ability. And we also kept kind of changing protocols. There was at one point in time where this convalescent plasma thing came up, and there were publications in favor of convalescent plasma, and they were all observational studies. So whatever publications came were observational studies which had their own selection bias, and they showed benefit. And then we started using these things. And then when the randomized control trials came, that is when we had to actually kind of change. And though some hospitals changed the way they were handling patients, there were some hospitals who didn't change. And this care was not uniform throughout the country. So, I mean, our challenge was that to get correct information about how to treat these patients. And just one more thing I want to kind of tell you is about infection control. So initially, when the guidelines came about how to protect people, there was these guidelines from the WHO, etc. And sorry for that.
ICU 7, bed number 47.
I think I'll just... You can take it from here. I'll just pause it. Yeah.
Thank you, Dr. Singhal. We'll pull you back in once you've dealt with the patient that you're dealing with right now. I wanted to go around the room and ask, and I know there's the methodology question that we should discuss, and I guess my request on that, and I'd like to A, discuss it later, and B, my request on that would be if the panelists could sort of very simply, like I'm 5 years old, explain to me what the controversy really is and what the competing methodologies are. But before that, so that we sort of stay on topic, a couple of quick questions. We talk about big data a lot, and there was a lot of fanfare around the mobility data, for example, other sources of data being used. In this pandemic so far, how useful has that been for policy, for generating evidence? So we talk about big data for a lot of things. This is probably the biggest test case for big data, and has big data really proved itself? Is there a long way to go there? So that's one question. The second question is, we've also talked about disease surveillance, and if you were advising the Ministry of Health or the National Digital Health Mission on disease surveillance, what would some of your key recommendations be, given where we are right now? So I'll go around the panelists and maybe come to Dr. Singhal right at the end. Dr. Agarwal, maybe we can start with you.
So the two questions that you have, one is that what was the advice to be given. That's the second one. What was the first one?
The first one was, what has been the utility of big data? Right?
The utility of big data. Actually,
yeah.
as far as I am aware, while the big data and data analytics has been of some use, but it has not made a very great impact in the pandemic, probably because the analytical tools were not designed for this purpose, or could be some other reason. I'm not very sure, but I haven't seen a very major impact of something which we got through analytical tools. Regarding the second question, for future pandemics, so similar, the advice would be to report the data in as granular form as possible and as quickly as possible. Because quickly is more important, I could say, because the earlier the data comes, the analysis can be done, the predictive models can be run, and corresponding feedback be given more quickly.
Thank you, Dr. Agarwal. Professor Menon?
I agree with Manindra that I don't think that the Google mobility data or the sort of stuff that we've got from there has been very useful in terms of being predictive. I think the only real use is to try and understand the stringency of a lockdown in terms of overall reductions in mobility, but nothing very much more useful than that. They may be useful in more granular models, but not with most of the other models that we have currently. So I think there is a role for big data that latches on to your second question. The problem is that the data we have is very patchy and distributed across different government agencies. Ideally, we'd like to know the consequences of infection before and after a vaccination, after 1 dose versus 2 doses, depending upon the vaccination, depending upon a prior infection, and what the clinical consequences are for someone with some pre-existing condition versus without them. If you have combined information about patients, then you can be truly predictive. Right now, we have information about infections, but we don't have anything about the clinical consequences of those infections. There's information about infection, but we don't know whether these people are being reinfected or they've been infected for the first time. We don't know if this is a breakthrough infection following 1 vaccination or following 2 vaccinations. There are small hospital-based studies that Professor Singhal described, but those numbers are small. Technically speaking, all of this information exists with the ICMR, exists with other agencies such as Arogya Setu, Ministry of Health and Family Welfare, and the CoWIN app for vaccinations. But I don't see them as yet, maybe I just haven't seen this, being integrated together with information on the clinical side to be able to be really useful. I think data integration, collection integration are both very important for us to be able to understand long-term what the consequences of COVID-19 are. Regarding surveillance, certainly random surveillance is important. Looking for syndromic surveillance, looking for clusters of cases with similar symptoms across the country, looking at excesses above a background, and at what point will you call that an excess? Doing prompt genomic surveillance on those cases to see is a new variant responsible and what its properties might be. All of these should be part of any long-term surveillance program. I think we're not there yet.
Thank you, Dr. Menon. Dr. Laria?
So I echo everything which Professor Manindra Agarwal and Professor Menon had said. So additional points are there that I believe that in the big data, that kind of appetite in the health sector had not been there to use and interlinkage of that data. So it had not been used sufficiently, but also that require that kind of attention, infrastructure, and prioritization before when it can be used. And when we are in the pandemic, the priority is limited resources were being used very differently. Of course, it could have been used better, but that's the current scenario. Coming to the surveillance part, of course, we would say that in the last 18 years, India had a fairly evolving, and I must say, every passing year, India's disease surveillance system in the last 18 years has strengthened, integrated disease surveillance project, and that's what could be utilized for this pandemic response, including some of the surveillance systems, some of the human resources which were available under various programs, including National Health Mission, which really worked handy. And this is a proof that if you want to strengthen any system, be it surveillance system, you need to invest over a period of time. And I must say that the disease surveillance system has improved, and it came up to the up to the certain level during this pandemic period. It has strengthened a fair bit. Having said that, I would still say that the challenge in disease surveillance system is, one, there is not enough investment and enough technical inputs from the subject experts to design those kind of approaches that we can get additional information, ILI or SARI surveillance and other things, though they are theoretically discussed, but the methods and approach are not designed well, not enough allocations are made in those areas. So 2-3 quick points. What should be done? We should definitely, that's the one area where government should commission independent work and see that what are the learning for disease surveillance and how the learnings from pandemic can be utilized for further extending surveillance system. Of course, that requires a human resource capacity building, some investment, and more importantly, it requires those Indian states which have a weaker disease surveillance system to invest and work on those areas. But the learnings are fairly well known. It's time to intervene, and if governments have desire, it can be done.
Thank you so much, Dr. Laharia. Dr. Singhal, I'll come to you if you're free now.
Yeah. No, I just wanted to kind of add that, we are looking at, more analysis of the data which is available with the government, because they have data on deaths, even though that data may be underrepresenting the number of deaths, but at least we look towards publications because they can be very large sets of data which they can analyze regarding what were the kind of people who died in our country, so that we can actually prioritize booster vaccines or new vaccines for these kind of people. Then, as was said earlier, we are trying to look for any integration between the vaccine data and the disease data, infection data, because so that we can know who are these people who were getting reinfections, who are these people who died despite vaccination, and what should be the policy for booster vaccines in our country, because we understand now that COVID has a distinct epidemiology in every other country. So how do we go ahead from here? What should we be doing? Whether we should be vaccinating or not? So, I mean, there are so many questions which are still unanswered. So basically what we are looking for is kind of analysis of the data set which is available because I think there is huge amount of data regarding the number of infections, the distribution of deaths, etc. And as a pediatrician, we are also keen to have more transparency into the disease spectrum in children, because there's nothing available so far that, because we have to also take decisions about pediatric vaccination. And, as a pediatrician, we keep getting this question about, should I give the vaccine to my kid, especially for vaccines like Corbevax, for which there is no peer-reviewed publication yet available. And it should definitely be, because the disease is so mild in children that, the vaccine should be very, very safe. Only then we can recommend. So that is why we need more information about the pediatric disease spectrum, which happened in our country during the pandemic, etc. So, and also some information about how these vaccines performed, what was the efficacy, etc., or effectiveness rather of the vaccines, because right now we have just small studies, but we would like to see, more analysis of the data which has already been collected.
Absolutely. Thank you so much. And I think with systems like CoWIN, India should be able to produce better data, especially on vaccines, just given that we have large-scale systems already deployed, much faster than many of the Western countries who actually track vaccinations using pen and paper right now. So just to summarize, what I'm hearing here is what would be recommended is granular and timely reporting, a lot of emphasis on data integration, all the way from a positive case to clinical outcomes, which frankly we haven't really seen much of, and also then looking at the disease spectrum in children and evidence around children. Because I also feel, the question I think we'll all ask ourselves is that, what has frankly the impact been on children over the last 2 or 3 years, not from the disease as much as but from the schools and the schools being closed. And I think we'll only learn more about this as the years pass, especially on learning outcomes, etc. I'll quickly go to some of the questions here. There's a bunch here, so I'm just going to scroll and pick up a few. So one question here was that, did we see a difference of state-to-state variation in availability of data? Would any of you like to comment on that?
What's that? Could you repeat the question, please?
Did we see a state-to-state variation between different states on availability of data and reliability of data, or was it quite uniform across?
In my experience, it was pretty much uniform across these states. And here I'm talking about the reporting of infections. One can have a lot of debate upon reporting of deaths, and that debate will never end. But infection reporting was pretty much similar, very similar across states.
So I just want to add that for Mumbai, we had this, we could see a dashboard every day which would tell us the distribution of the cases, age distribution of the cases and deaths. And that was actually good because the UNICEF says that 0.3% of the entire deaths due to COVID in the world have been in children below the age of 18. And when we looked at Mumbai data, it was nearly the same. So I think but we don't have this information from other parts of the country. So I would say that Mumbai data, at least there was more granularity. We had more information and not just the number of infections.
I think just a 30-second point that this is what I was talking about, that we studied the data being reported by various Indian states. That was for a period of 22nd May to 5th of June through online portals, around 100 plus websites. And that's what the paper we have published in PLOS Global Health on 15th of April. It's Varun Vasudevan et al. So the point, what is one of the key findings from that is that data quality was very variable across all Indian states. Some were doing better than others, and there was a lot of variations. And final point here is that we also know through sero survey, which we discussed earlier, that the case to infection ratio was 1:6 in Kerala to 1:70, 80 or 100 in Bihar, Uttar Pradesh and Madhya Pradesh, which reflects the overall data recording, but also health system capacity also. So it cannot be a simplistic approach to that, but it conveys that wide variation in the data, and we have studied that.
Can I just come in here? Because I think there is a serious confusion in the meaning being assigned to the quality of reporting. Dr. Laharia has a view that if your reporting is by a factor of 100, then it's poor reporting. If your reporting is by lower by a factor of 5, it's better reporting. I hold a differing view. My view is that if your reporting is consistent, it doesn't matter by what factor it is less. It is good. The reason it is good is because I can estimate by what factor are you underreporting. And then if it is consistent, then I can consistently estimate that. So from the model, I can get actual number of cases very easily. But if your reporting is inconsistent, then I have a problem.
Oh, just 30 seconds. I broadly agree on the second part. That's what I said, that this is reporting. The case to infection is also health system capacity, the laboratory capacity, human resource availability. But I was talking about the broader first part. There is a wider variation in the reporting, which is also a data reporting system issue. But second part, Professor Agrawal, I agree with you that modeling can be done, and some of that is definitely useful still.
I just want to add that in our models, we can see how this multiplier changes with time. So initially, for most Indian states, they were around 100. You were underestimating at least by a factor of 100, 120. But as time went on, that number came down to a factor of about 20 to 30, for example, in states like Karnataka and so on. So this is something you can put into models. It's interesting that you can do that.
Thank you. There's a couple of questions. I know we're coming up on the end of the session. We've got about a couple of minutes. I'm going to skim these questions and pick up the questions that relate to data. There are some questions around clinical evidence, which I think this might not be the best forum to address that. But there's a question here around data, and as the panel suggests, decentralized data analyses and resultant implementation, or a dedicated centralized data repository and analysis agency. Which approach is better? How to build capacity for the healthcare sector to better utilize big data?
Well, I would say have a centralized data repository and allow everybody to make use of it. So decentralize the effort.
Yeah, decentralization helps states who are doing a better job, so you know what states to trust, etc. But finally, they should be fed into some sort of centralized system so that the data is just available more easily rather than having to go refer to individual states. So some combination of both of these, I think, allows states to decentralize as much as possible the collection, but still to be fed in at a later point to a common central server.
Dr. Laria, Dr. Singhal?
Yes. No, I agree that, the data should be available for people to analyze and because there's such I think a lot of useful information can come out from what is available, and there would be a lot of people in statistics, etc., who could do a good job in analysis of this data. But they'll have to set it free, I guess.
Yeah, I have no point.
No, absolutely. I think this is coming out, loud and clear from the panel. As Dr. Agarwal said earlier, it is granular and timely data available in the public domain. And obviously, there'll be different ways of doing that. A couple of quick questions before we close. One is, where is the data? Can you tell us where age-wise data has been published?
Sorry, I didn't get the question.
So there's a question from an attendee, which is, where is the data and where has age-wise data been published on COVID?
So the age-wise data is not easily available. It's only for Mumbai that we have it, but we don't. I don't think we have it for the entire country. In fact, we don't really have any information apart from the number of cases as to this. So that is. But you may have small studies, regional studies, which may have told this. But generally speaking, there is data from the UNICEF and other countries which have published age-wise cases also. But for India, I don't think it's available in the public domain. For Mumbai, we have it. Dr. Laria, you have looked at that data.
No, well, primary data is, of course, with the government, but some of the analysis have been presented by Ministry of Health during the press conferences on the age distribution of various cases. But these have been very far and few, like once in every 3 months or at variable frequency, but the data, so to say, is not available. The analysis or summary reports have been made available occasionally. That's a short point.
Thank you. I think we are at the top of the hour and we've gone a little over the hour. I actually have a lot more questions that I can ask you, and I'm sure the audience does too. But I think we'll have to call this to a close. Thank you so much for spending your afternoon with us, and really glad to have you all. Back to you.
Thanks so much, Dr. Nair. That was a superb discussion and I was riveted. And to those of you who have asked questions and you have not had your questions answered, I think what Dr. Nair was doing was he was trying to choose questions relevant to the topic of his panel. And obviously that is something that we will try to do going forward. But our request is, if anyone has time, even if it's not in this panel, maybe the next panel, if anyone wants to take a stab at one of those questions, please do so. We'd be grateful. And of course, one of the things we spoke about, or we kind of hinted about in that panel, was the idea of trust. And some of the questions bear this out as well. As we can see, some of the questions are related to vaccine hesitancy or questions about vaccines. And a major challenge is how to build trust among the public going forward for healthcare, in our hospitals, clinics, through messaging, and of course, digitally. And to take that question, we have our moderator for the next panel. She's my colleague at Boom Live, Tanvi Shukla. She's the consulting editor, and she does a show called Simplified. Tanvi, it's over to you.
Thanks so much for that, Venkatesh. And I think actually that was a perfect segue to the next conversation that's lined up. Thank you to all the panelists who joined us for the last conversation. Extremely insightful. And I think I agree with Dr. Nair when it comes to availability of data and how to look at data and where to find the right data. That conversation could have gone on for a longer time for sure. But let me say good afternoon to everyone who's joining us right now for this panel now. Building user trust and in digital and in public healthcare. Now, forging public trust is integral, obviously, to developing and maintaining the health and well-being of healthcare stakeholders, be it individuals or communities or society in general. Hence, it is the need of the hour for healthcare practitioners and policymakers to instill the notion of public trust to improve the public's health and strengthen engagement dynamics between the public and, of course, the public health system. The panel discussion today that we're going to have will strive to take this conversation forward by addressing and highlighting the ways in which this public trust gap between the community stakeholders and the healthcare industry could actually be bridged, particularly in digital and public healthcare. So I'm not going to waste any time. Let's straight away welcome our three speakers this afternoon. We have with us Dr. Mohit Mathur, who is currently heading the Department of Critical Care Medicine at Max Healthcare with more than 15 years of experience. Dr. Mohit is also a member of the Indian Society of Critical Care Medicine, European Society of Critical Care Medicine, and the Indian Society of Anesthesiologists. Dr. Mohit was the recipient of the Sushruta Award for Clinical Excellence at the annual Max Healthcare Awards in 2021. Our next panelist is Dr. Kumar KV, who is a senior technology and security leader with over 20 years of proven experience in digital strategy, in innovation, systems designs and development, along with planning, budgeting, enterprise architecture, information security, and of course, privacy. He's currently the group head of information technology at Narayan Health in Bengaluru, where he is leading a high-performance team comprising 200 associates across the organization's software development center and the IT operations department. And our third speaker is Dr. Banali Das. She currently helms the role of a consultant in lab medicine at the Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute with over 16 years of practice experience. Dr. Banali Das is the technical committee member in the International Federation of Clinical Chemistry and Laboratory Medicines, a 6-member committee on standardization of thyroid function tests worldwide, and the corresponding member of the IFCC Committee for Reference Interval and Decision Limit. She's the only Asian member in the IFCC, the CSTFT that I just mentioned. She's also the Joint Secretary of the Consortium of Accredited Healthcare Organizations. Big hello to all of you, and of course, to all our other participants in this conversation. Let me just start off with a very basic question to set the ball rolling. What do you see as the biggest challenge in building user trust in digital and public healthcare? I mean, I, as a layman, as a non-healthcare, stakeholder, would personally observe that rapidly evolving concepts for a novel coronavirus actually led to a lot of doubts within the minds of people, a lot of questioning about what's going on. I always found it extremely tricky to explain to people as to why mask had been necessary and mandatory all this while, and why it's not important anymore, or why it may again become the most important thing a few weeks from here on, or why a vaccine, the gap between 2 doses should be 1 month, or suddenly now it's 3 months, and so on and so forth. You get the gist of it. So essentially what I'm trying to say is these evolving concepts, as we got to know a lot more about the virus, also meant change in how we were tackling it. That did bring about a lot of confusion and doubt and lack of trust. But that's my view as a layman. I'm going to hand it over to the experts really to share their views. In fact, let me actually first start with Dr. Mohit Mathur. Go ahead, please. Okay, I'm going to check on what's happened there, but Dr. Banali Das, would you like to take up this? What, according to you, is the biggest challenge when it comes to building trust?
Thank you for the organizers for inviting me. And yes, the roadmap for healthcare, like involving strategies for harmonizing, communicating, and integrating with all the stakeholders. So the gap is between all the stakeholders, like the communication between the clinicians and diagnosticians, then the IT sectors, like where we know the big data and the digitization or digitalization. So the gap between the communication gap between all stakeholders, or harmonizing and communicating and integrating all the stakeholders or the industry in order to formulate the guidelines for assisting correct measurement, diagnosis, and management of diseases, and reduce the cost burden, and while maintaining the quality and patient safety. So I find this is the major gap, like where we are not communicating from each and every we are working in silos. So recently we started some project with Digital Health Department of IIT. So I realized many of the things like implementation, how we can implement artificial intelligence or cloud computing or machine learning in our day-to-day practice, like reporting the acute kidney alert. This is or electronic health record. So sometime the cardiovascular disease, AI cardiovascular disease risk stratification. So we can actually implement many things in our day-to-day practice, but because we don't we work in silos and we don't communicate, so because of that we face a lot of challenges both in the public sector and as well as in the private sector.
Okay, interesting. And I do want to just very quickly follow up with you on why do you think that lack of trust or the trust gap really exists? Is it simply because each of the stakeholders are working in their own silos, or is there more to this?
There are more to it, because one thing is, of course, we clinicians or diagnosticians, we have a lot of technological gap or to understand the process, but COVID has done has given the quantum leap in understanding. Like 2 years back, when I used to not understand how to integrate my process with the patient, how it is very much important to integrate different centers, even for sitting here, I may monitor many of the lab reports from different centers or different resource poor setting. I can help or integrate the inventory management, like we realized during the second wave, how for each and every resource we have struggled. So I felt that the gap here is in India, that the digitization or digitalization, we are everything like vaccine monitoring. I think last panel, Dr. Tanu and everyone spoke about the vaccination hesitation. And because of that, many of the monitoring or even the lab reporting of our RT-PCR reports, many times we don't, or rapid antigen reports, many times there is a gap between reporting. So I feel there is more to it rather than the communication or harmonization. So I think we need to integrate between clinicians, diagnosticians, and all stakeholders, media, everyone. We need to play a very important and significant role, like how IoT, AI, and digitization and building the trust to patients or patient safety is patient empathy. I believe this is the most important criteria for anyone working in the healthcare sector, either private or public.
Okay, Dr. Kumar, do you agree that perhaps the biggest challenge is the lack of trust between the various shareholders and entities themselves within the sector? Only if you come together and are able to use technology better, will you actually be able to bridge the gap with the public as well?
Yeah. Thanks, Tanvi. And first correction is I'm not a doctor. I'm a pure technologist.
Apologies.
No problem. See, I think in my opinion, the lack of trust, basically stems from the fact that in the last 2 years, what we have actually seen is, one is the lack of verified sources of reporting, right? Because many of the information what causes misinformation or disinformation, because what we are in this digital decade, what humans are actually facing is basically an information war or an information overload, right? Which happens through various social media channels. So lack of verified sources through which people can understand and digest the information and then spread the good word, right? So there is a lot of conflicting information that is actually out there through all these channels. Then because India, as a country, from a public health standpoint, from a digital health standpoint, we haven't made the right investments in the health infrastructure, which meant that, everything was actually in paper and there were no digital health repositories available for which we can get back and understand how the data is actually collected, and which could have given us a ton of insights, which would have enabled us to communicate better, to the layman who's actually out there so that he or she can understand that and take appropriate action, whether it be masking, the COVID-19 is just an example. I'm sure that more such outbreaks will actually happen in the years to come. And lack of scientific evidence, because they said wear a mask, 2 gaj ki duri, wash hands, and then they, and then there were, and even Dr. Tanvi had actually highlighted in the previous panel that lack of protocol standardization itself caused a lot of issues, whether what to administer, when to administer, and they had to roll back a number of protocols. Most importantly, lack of trust also stems from the fact that there is lack of engaging with proper leaders. See, in a country like India, it is a multicultural, diverse society where there are billion people that are actually there. It is not just the political system actually trying to engage and conveying that meaning of trust. You require a very multimodal, multicultural, diverse people to come and reinforce the message to people, which means that engagement through community leaders, engagement by big shots or big medical doctors, medical professionals, through sports people, right, through various mechanisms. If the message could have been percolated much better, then it has a better reach. Believe me, all we are seeing is we are all in urban areas and we are seeing all this information, but there are people who don't have access, who are at that last mile of the healthcare delivery that we actually call. How do they actually hear the messages? Because what we see in urban is we have a mask, we put that N95, but the people who are there in the last mile, they have not even heard about a mask, right? They would have had a piece of cloth which they would have folded and gone, that has been there for several hundred years. So I think lack of engaging appropriate people who are for that appropriate community and getting that message in the way in which they would be able to understand has resulted in this trust deficit is what is my opinion.
Okay, lack of communication to people who need to know the last mile communication strategy as well, extremely important. I think we, when our vaccination campaign started, even though everybody told us at that time that, India has already an exhaustive, very large setup, mass immunization is set up, and we will not have problems. We did encounter problems because now we were looking at vaccinating adults. And that was not something that, especially in the rural areas, it was extremely difficult to convince the adults to come and get the jab. We did see a lot of innovative, communication strategies being deployed there by the local administration to try and reach out to the people. So maybe if you expand that and say we need to do it at a larger level, constantly about all the evolving healthcare policies and treatments and technologies, then that would make it easier. I believe Dr. Mohit Mathur is with us now. I think we lost the connection with him for a bit. Dr. Mathur, we are starting off this conversation by understanding what you think is the biggest challenge when it comes to building user trust in public healthcare. Okay, he may be having a bad day with this connection. So I'm going to come back to him once we have that line through with him. But let me take it now to the next step. And I'm going to now split it into various kind of deficits that exist. For example, Mr. Kumar, let me ask you this. There is lack of trust in doctors. There is lack of trust in medicines and treatments. There's lack of trust in newer vaccines that are coming about. And then there is lack of trust in technology. Let's talk about medicines. That was something that also came up in the last conversation. Dr. Tanu Singhal was speaking about it, saying, in between all of these new drugs came in, there was so much of conversation about remdesivir, became the most sought after drug, to a point now that we're being told it does nothing for you, actually, unless you are at a critical position. So how do you build that trust where people believe that the drugs they are being asked to take are actually good for them and beneficial?
Though I'm not a doctor, I can only talk from a technology standpoint. I think the availability of scientific evidence, with regard to any medication has to be there. And, if that medication or if that course of treatment has been, given to a larger course of, or larger cohort of people, which did not have any sort of bias, right? Because what would have worked for a certain demography of people need not actually work, for another demography of people, because the genetic structure, or there are various changes that are actually there. So, in my opinion, because of the lack of scientific evidence, that people basically lost in trust in that from a medication standpoint. But if it would have actually been available, we would have been able to bridge that gap.
Okay. Dr. Mohit Mathur, I think you'll have to unmute yourself. I think you were muted the last time.
Yeah, I'm online now.
Yes,
Thank you.
I can hear you. Go ahead, please.
So in fact, I did miss out on the first few minutes of the conversation, but thereafter I could hear. And so I got a fair bit of idea what is the discussion going on. So Tanvi, I am a bit of an optimistic person. So whatever happened, we are all free to criticize, and we all have our reasons to criticize whatever happened and how we dealt the situation. But I will give you the perspective of physicians who were in the middle of that crisis, who were right in the middle of that battle. And we felt that we means the whole country, the people, the physicians, the private healthcare, the government healthcare, we came along very well, and we dealt with this situation in a very well structured way. There can be criticisms, but with the limited resources that we had at the beginning of this thing, and as you are rightly saying, the data problem, still we managed in the end to manage this situation very, very well. Both the main problem of COVID-induced admissions and the vaccination also. Why I'm saying this is, we used to look up to West prior to this particular COVID for all the literature. Our own study publications are very, very deficient. And during this epidemic, we found out that we cannot no longer rely on West for that guidance. Like suppose you're talking about remdesivir. Remdesivir, WHO told us in the middle of the second COVID wave that remdesivir is not useful. And our own experience till that point of time was that remdesivir is useful, but if given early in the illness. Now, remdesivir is an antiviral drug. And common sense tells her that antiviral will be effective in the first 7 days of illness when the virus is replicating in the body. No point giving it beyond that phase when the patient has moved from the viral illness phase to the inflammatory phase. But initially, the whole world bodies and the WHO was telling us to give it after 7 days in moderate disease. That means by the time the oxygen requirement had already started. So, and then they later on backtracked and said that it is not useful in that category of patient also. Recently, we get a major trial in NEGM, which is telling us that if used early, remdesivir is a very, very potent drug, and which this particular thing is also supported by our own experience. So whatever we did in that period, we were clueless. We did not get any guidance from any world bodies. WHO was flip-flopping. There was no other world body guiding any of us. Any of us means any of the Western, any of the third world countries. So within the limited resources, with the limited data set we had, we fared really quite well. And the boundaries between the civil healthcare and the private healthcare, all those boundaries melted. And in the end, I think that we came out very well. We could have been fared much worse, but still we managed to come out with flying colors. All those who died, all the mortalities, nobody can deny that did not happen. But still, as compared to many other countries, we fared very, very well.
Okay, no, Dr. Mathur, let me also specify that for not a minute. Am I saying that the lack of trust is because we did a bad job at all? But it's normal human tendency. When you don't understand something, you don't trust it. And when it comes to medicine, not too many of us understand it. Even as you and I, and we're having this conversation, and we've opened it up to questions. One of the questions that has come is, why should we be taking a booster dose even after we've seen so many deaths and breakout infections take place? That's what we're trying to reach out to and fix. How do we do that?
So as of now, regarding the booster doses, anybody who had a COVID in the third wave, that is in the month of January, the recommendation is to wait for 6 months at least, because already enough antibodies are there in the body and we don't require any further jab or booster. And the other reason against getting a booster is every few months, the virus is mutating and it is going into a the new variant is coming up. So the older vaccine will not be very effective for the new variant. So I don't think there is any reason to panic and to queue up in front of vaccination centers for a booster as of now. Most of the population, around 60 to 70% of the population, did get the infection in the third wave, and they should not be hurrying to get the booster shots. Booster also has certain side effects, not because of the vaccine per se, but because of the hyperimmune response that the booster can generate in a patient who already had a recent COVID infection. So again, booster should not be, it is not a mandatory thing. We should wait for some more time, at least for next 3 months before taking the booster shots.
Okay. There's been much conversation when it comes to building trust for the drugs that are being used for a treatment. But let's, for a bit, also talk about diagnostics. Dr. Barnali, how do you build trust in a diagnostic system? Again, if you take the example of COVID, every few months there was some change in thought and the process there itself as to how to detect it. So it becomes tricky, doesn't it?
True. Like Dr. Mohit said, here again, the right information at the right time, very important, because we believe right patient, right time, and right diagnosis. So many times what we have seen during the during the first wave and second wave, that in WhatsApp, people are like getting the advice, like this test to be done, and this all the battery of tests they have advised to do for even with 2 days mild fever. So because of that, there is a lack of trust, or sometimes patient deteriorated with because they were doing monitoring and getting the treatment at home. So this diagnosis, as there is a major change, our RT-PCR is initial period, it was not available in a resource poor setting, or in the in Tripura or Leh, Ladakh. So in that, the rapid antigen test was available. Then ICMR has done a beautiful job. They have actually empowered the diagnostic ecosystem totally, and with the supply chain management from all the IVD sector people. So because of that, there is a right time, right test, and right patient, very important. And also the digitization played a significant role. Like people sitting here and can do the digital monitoring, or sometimes there is a home-based home collection, and also reporting of the RT-PCR. So everything was available, although we know there is a big data, and even there is different model for epidemiological model, and based on those data, garbage in and garbage out. So many times this was those data was not utilized properly, and many times it was not actually there was not a proper representation of the data. We have not got the correct figure because of many have done a rapid antigen test or RT-PCR. So this, because right information at the right time is very important. So these were the challenges to build the trust with the consumer and build the trust with the patient.
Yeah. So in that sense, then, Mr. Kumar, did the pandemic actually help bridge the gap when it comes to trust in terms of using technology? Are people now less suspicious of using new age technology or getting a remote treatment or remote diagnostic done?
I think the pandemic has helped us to leapfrog in terms of the digital health infrastructure, but the healthcare organizations which are offering digital solutions, they are also trying to find the right fit for clinicians and patients. And many of these trust issues when it comes to technology basically stemmed purely from the fact that because of privacy issues, security issues, poor digital experience. The first experience or the first digital encounter that they actually was very poor, and lack of trust in digital tech companies, right? And in a recent survey, of local, by local circles, 60% of people wanted to use digital health technologies, but are hesitant to share personal details beyond health and medical records, or they want 60% of the people they want to create health IDs, the Ayushman Bharat, digital health IDs. That's a beautiful thought process which the government actually has to to ensure records are portable. But then the privacy implications of it, who's going to handle my data, what sort of information are they going to collect, right? I think those areas need to be addressed, and if that is addressed in a very structured manner, you definitely see that trust getting established, and the experience also, or the digital adoption also going up.
Yeah, so let's get a little, let me cite a few examples and then get you back on this conversation. I also have a question from Dr. Fuad Ali, who says, looking back, was the government public health system confidence building measures adequate? You mentioned people's hesitancy. We saw that one of the state governments, I think it was the Kerala state government, right in the beginning, that came out with their own platform where they wanted to collate all the information about patients such that it's easy to track everybody. And no matter where you are, you're able to access those records. Now the government, the central government, also has a similar system in place. But the biggest concern that everybody has, like you said, is privacy and data security, especially when it comes to a public entity running it, not a private entity, but some kind of a government which is in the center of it, controlling all things. Are governments doing enough to allay those concerns?
No, I think the government has taken significant measures. I think the last 2 years, we would definitely say, I think we have to see things from a positive light, like Dr. Mohit was saying. We've learned a lot of lessons. One is the government has, increased the investment in digital health infrastructure, which is a step in the right direction. The establishment of the National Health Authority and the National Digital Health Mission on mission mode is also a step in the right direction. And the entire architecture itself has been planned out in such a way, it's a federated architecture, so that the government doesn't actually hold all the data. They don't have a large holding tank where they're going to collect all this data, basically keep processing that. Maybe that is something which other countries actually doing. In our thing, how data exchange basically happens, it's in a federated way, right? Which means that very similar to what UPI is today is what Health ID is going to be for the the government of India when it actually comes to, or when it comes to India as a country, when it comes to from a health standpoint. So what we are actually having is a completely different process. We are not aping the West in that, especially. So by having a federated architecture, we are ensuring that each person's data is there with that particular provider, and if there is consent that is actually provided, then the data basically get transferred. Now, when will basically the government actually have data? So they also have come out with specific data policies which says that what will they do with the data, and with the upcoming personal data protection bill of which is actually there. I'm very, very sure that we will be able to, the government will be able to have, maybe a de-identified or an anonymized set of health data through which they can, make inference and ensure that appropriate measures are deployed to augment public health wherever required. From that standpoint, I think we are in the right direction. Of course, in a large country like India, it will take time, and it requires multi-party, it will require stakeholders from various agencies to come together to deliver this. So we say that we are in the right direction, and the government is taking all possible steps to address that in terms of budget.
And I think beyond that, when we talk about building trust, yes, go ahead, Dr. Martin.
Yeah, thank you. So totally agree with Mr. Kumar. In fact, one of the single biggest advantages that has come out of this crisis is that people have started prioritizing health for the first time. And this pandemic has strengthened digital health space. And now is the great time to strengthen the consumer trust in that space. So there is no need to convince anyone right now. People are themselves trying to find out about the best digital health solution out there in the market and trying to embrace it. So we just have to build up on this momentum. We should not let go of this opportunity. And like what happened in March, the previous COVID outbreak, not COVID, coronavirus outbreak, the MERS, Middle East Respiratory Syndrome that happened in 2012. Had we learned the lesson then and taken appropriate precautions, we could have avoided this situation. So now is the time that we learn from this, we build on, we take build on this advantage right now and prevent any such future episode from happening, because there is an Israeli app which layers maps over symptom tracking. People are encouraged to enter their symptoms into the app, and the government layers map over it. So they can pick up early from which particular area people are reporting more symptoms, so they can pinpoint the origin of the outbreak in that area. So we need to utilize this time, this opportunity, so that we utilize this and we prevent any such future outbreaks. Because as per United Nations Environmental Program, every 10 to 15 years now we will have some zoonotic disease outbreak. So this is a norm now that we will have to live with. And we will have to utilize this current experience to make ourselves stronger for a next possible crisis, and we should be able to avert it. That should be the objective.
Give me an example. Give me an example when you say we need to use this opportunity and capitalize on it. Who is this we, and how well can we do it? One example.
So who we means, I think I will be able to broadly segregate this we into three categories. One is the physician group, the healthcare providers. They, as of now, are not very well acquainted with the digital health tools. So now we will have to brace up ourselves and improve our understanding of these tools, so that then we can communicate to our patients about the useful of this. Second is the urban lot, who are already in a position to embrace this technology for their betterment. The third most important group is the underprivileged, those in the remote areas, those who elderly groups, disabled groups, who deserve the healthcare or contact with healthcare most. So I think that would be the most problematic area. How do we utilize this experience and reach out to that third group who are still not getting the healthcare contact? And with digital healthcare, it is very easy to even involve that group also.
Okay. We're almost out of time. Our next speaker is also here ready. So I'm going to quickly ask Dr. Banali Das to you first, and then to Mr. Kumar to give your closing comments. Go ahead, please.
Yes, like Dr. Mohit said and Mr. Kumar said, this implementation of the digital health, or along with all the stakeholders like clinicians, diagnosticians, and everyone like who is giving the information, like media. So we should communicate and bridge the gap between all of us. And one is the clinical decision support that is actually less utilized, we realized, in both public and private sectors. So we take the expert view, like the clinicians. Even the COVID, we have seen a lot of model, SARS model, Sutra model for prediction of the epidemiological trend or prediction of the Omicron waves from the South African incidence and prevalence. So like if we take the expert view, if we take the view from all the stakeholders, and if we can build clinical decision support in our open digital healthcare ecosystem, that's very important to make it open rather than working in silos. I may be doing some work, or you may be doing some work, Mr. Kumar may be doing excellent work in his this thing, but this is not open to everyone. So I think the digital health mission of ours to work towards this open digital health care, I think this is the roadmap ahead.
Well, on our part, I can say that we would definitely love to have a lot more of these conversations, and get the ball rolling from our end at Boom. Mr. Kumar, would you like to add anything?
Yeah. So I think in healthcare delivery, there are many digital processes which are operating beyond what the customer sees. So every process that we build, a layer of transparency needs to be embedded whenever it actually comes to sensitive health data. Organizations that monitor and report on digital trust with real-time accountability will be the new normal for value creation in digital era, where personal health record information is a valuable commodity. Believe me, a healthcare record costs $369 when compared to a regular record, if somebody hacks a personal health record. So as users get, or as public gets more informed, managing data and protecting the privacy of the data will be an important barometer of how healthcare enterprises will be trusted by their wider stakeholders. So that is my 4 points on
Well, that was a brilliant way to actually summarize this. So we've got transparency, accountability, credibility of the institutions and the data that is available, that is being used, and of course, communication, really to take it out there to the public. These are the few things that need to be focused on when you build further on trust and public trust. And like Dr. Mathur said, now is the best time to do that, as we've already got the people's attention because of this pandemic. Let's build on that. With that, thank you so much to all of our panelists for joining it. I'm going to hand it back to Venkatesh. Over to you.
Thank you so much, Tanvi. That was an extremely interesting discussion and lots of lines of inquiry for us to consider here at Boom. Two more key events coming up. We have a keynote speaker now, so don't go anywhere. We move to an address now that is kind of a good segue once again from this last session. We have with us Dr. K. Vijayaraghavan speaking on the title, Overcoming the Vaccine Challenge in India. Dr. Vijayaraghavan was the principal scientific advisor to the Government of India from the 3rd of April 2018 to the 2nd of April 2022, a really hot period, of course. Prior to that, he was the Secretary, Department of Biotechnology, Government of India, in 2013 and from then to 2018. He's also a distinguished professor at the National Center of Biological Sciences, TIFR, and was the NCBS director till 2013. Dr. Vijayaraghavan is a fellow of the Indian Science Academies, the Royal Society, the Academy of Medical Sciences, and a foreign associate of the US National Academy of Sciences. He was awarded the Padma Shri by the government in 2013. Doctor, it's over to you now. We'd love to hear what you have to say.
Thank you very much, Dr. Venkatesh. One of the nice things about sessions going beyond their time and the next speaker arriving on time is I get to hear the wonderful conversations in the previous sessions. And that was very, very illuminating. The point which was made then relates to what I will be talking about now, is about how one can have digital access to everyone in a manner where it's personalized and security is also taken into account. There was also another important point made there, that is it possible through digital approaches to get a sense of the health of the population, particularly, for example, if fevers are growing in some sector and not in others, and this could be early warning signs. So let me from there take on to where we need to go about vaccines. Now, the characteristic of vaccines in the current age, as distinct from the previous era, are important and significant for us to keep in mind. In the previous era, we had no hurry on our hands. We had to have vaccines against smallpox, against many enteric diseases, childhood vaccine preventable diseases, and so on. But they had one important characteristic there. These were all, for good or for worse, efforts substantially led by developed countries with a view to save the world, particularly in less developed countries, having saved themselves in many ways for pediatric illnesses and so on. In other words, there was no urgency to have vaccine deployment on scale for vaccine preventable diseases in the low and middle income countries. They rolled out steadily over decades. They had an enormous impact. Indeed, if you look back and ask, if this were 1947, many of us on the screen are likely not to have survived and gone past childhood. And the reason for that is improved healthcare, and amongst that, vaccines have played an enormous role. So that was the past. Now, those vaccines they fell into broadly two categories: attenuated viruses, and these were used, in many cases for as vaccines. Polio is an example, rotavirus is an example. And the other were inactivated viruses, against whom, along with adjuvants, antibodies were raised, neutralizing antibodies were raised. Then came a new era which we're seeing today, in which this started about more than a decade ago, where there were vaccines which were expressed by recombinant DNA methods. Proteins were expressed on virus or bacterial surfaces, and they were used for immunization. And these kinds of vaccines were very, very important and had a great impact. And more recently, we've had the mRNA vaccines. Now, one of the important characteristics of the vaccine industry is something which has prevented also their deployment on scale, but has also resulted in vaccines being developed. And that is very simply this. Vaccines, by and large, are a volume business, and they're a volume business with low profit margins for many of these companies. So they will make the Western companies will make high-end vaccines for products which are very important when people go on tourism, or for other projects which are part of the national immunization system, which, cost is not such a very important criterion, measles, for example, and so on and so forth. In the low and middle income countries, enteric disease, meningitis, many new viral diseases are all very, very important. But those are not attractive for the big companies. The result of this has been the growth of companies such as Serum in India, companies in Indonesia, in Brazil, and these companies are growing their vaccine development on the back of science at the US National Institutes for Health, in many Western laboratories, some cases in Asian laboratories. And therefore, in other words, the vaccine development costs have been enormously subsidized by public efforts globally. Then, along with that, they partner with international charities to develop vaccines locally. These vaccine developments require enormous skill and are not to be sniffed at, and they require safety standards. But also, when you scale, it is one thing to make potential vaccines in laboratory at the bench. It's quite another thing to go through all the trial processes nationally and internationally and make them on scale. And that something companies like Serum, Bharat Biotech, Biological E, and many other new companies coming into India now have accomplished really well. So it's for no small reason that India is known as the vaccine capital of the world. 2 out of 3 vaccines administered to children globally are from India. At least I would say 250 million African lives have been saved by vaccines against meningococcal disease, against pneumococcal disease. So there are extraordinary, examples of vaccines being effective. Now, going ahead, what is the challenge? Typically, vaccines take, about 10-ish years to develop or more. They cost about, hundreds of millions of dollars, if not $1 billion to develop. And then, they're made against diseases which are already prevalent or endemic in different regions. And then there's a big challenge now in, getting it into the immunization program, who's going to pay for it and so on. With COVID, the whole world has been turned upside down. What took 10 years to develop now takes 1 year to develop. What, took, hundreds of millions of dollars has actually become even more expensive now, because you want to develop vaccines very rapidly without cutting corners. So it's not inexpensive. But the very interesting thing is India has moved from this earlier phase, which I told you, where vaccines were designed elsewhere and scaled up and manufactured here. So India was a vaccine scaling up and manufacturing hub. India has now become a vaccine developer hub, and there are dozens of companies now making vaccines at different stages. They will take some time to crack the global market and get on, but they're very, very innovative vaccine developers coming. In addition, the COVID pandemic has spurred the development of vaccines in the livestock sector. Foot and mouth disease and other diseases are widely prevalent, but there's every reason to believe that just as we've had a pandemic now in humans, that there is a real possibility of having a pandemic for livestock. And so that's also an industry which is going to grow. Let me end, and then I'll take questions, with a big challenge which we have. One of the consequences of the pandemic was that our big vaccine manufacturers, in particular Serum, initially was expected to serve not only India, but all over the world. But the severity of the Delta wave and the subsequent requirement for large-scale rapid vaccination in India meant that our commitments or our delivery internationally had to wait a little bit for our attending to our population. So there's an argument coming forth in countries such as in Africa and elsewhere that if you rely on supply chains of a few large producers to deliver to the whole world, then in an emergency, their reliability for other countries when the internal demand is so high is a challenge. Now, this may be a knee-jerk immediate reaction because, as I said, it's not a trivial job to manufacture vaccines on scale. And therefore, it's not a trivial job to set up and break the supply chain. Yet, this has raised an issue. So I would say there's an opportunity for Indian industry to go into different other contexts and in an open source manner, help set up vaccines and their development, take them through clinical trials, so that there are multiple nodes in supply chains which are modestly strong rather than a few strong supply nodes, so that in case of another emergency, vaccine supply globally, equity and access is ensured. For that, it's not just making a candidate vaccine in the laboratory, but going through the preclinical tests. Animal tests are very important and must be widely and speedily available, and going through the early stage trials, phase 1 and phase 2 perhaps, and wait in case of an emergency to rapidly go through phase 3 and deploy. All this requires capability, capacity building, and importantly, resources. There is a tendency in these sectors to say that why should I invest in a safety belt? Why should I invest in an airbag? And until the accident takes place, these things are not useful. But as you know, this is a wrong argument. You cannot buy a safety belt just as the time before the accident. You have to invest in it in your car in advance. You have to invest in an airbag in advance. And similarly, you must invest in vaccine development in advance, even though it is not immediately commercially profitable. This requires multilateral organizations internationally to raise resources and invest in obviously imminent potential threats, as also be prepared through development of capacity for tests which for diseases which we don't know yet and which may rapidly come. So this is a very big challenge, but we have the capacity, as we've seen in the pandemic, to overcome, even with difficulty, these kinds of challenges. So the road ahead is tough, but we know what to do, and we must do that by investing in resources and in capacity building, in addition to scaling up the capacity which we have. Thank you very much.
Thank you so much for that perspective, Dr. Vijay Raghavan. A lot of questions coming in, and I'm going to start with a very basic one, actually, because he's here talking about what the future of vaccines is going to be. And we've been speaking about vaccine hesitancy also today. We've touched upon it directly. So someone has asked a question, Arun Gaggar, there is talk of a fourth wave in India. And how serious would it get, according to you? How many waves will COVID-19 have before it completely disappears?
You know, these kinds of questions are understandable, but I would say at this stage, asking such questions is different from asking it at an earlier stage. So leave that particular question aside and look at it from the point of view of how these kinds of waves occur. There are three major components to it. One is how the virus itself changes. What are the spaces for change available to the virus? Once those spaces for change are available, and they're available in two broad ways. One, they're by infecting a large available population. And the second is by incubating, let's say, in a small number of immunocompromised people. Then the virus can change a lot. Now, this large available population is the second component. Because of prior exposure and vaccination, that available component for expansion of changed viruses or for them to change is substantially lower. So that's the second aspect. And the third aspect is massive immunization programs and prior exposure means that the kinds of cases which are coming up, even in terms of escape, are typically those which have mild symptoms. The changed viruses do not yet have resulted in extraordinary severity, and therefore the hospital system is not overwhelmed now as it was earlier. So going ahead, it is not unreasonable to think that we must take precautions and watch carefully, assay the cases and so on and so forth, and make sure that anything which is more troublesome which comes up is acted upon early. That capacity is there. There are some tools in addition to newly developing rapid vaccines. There are drug targets which are becoming more useful, and therefore one has to see how one can go to the next stage without having an overload of the system as we've had. Will this become chronic like with other diseases remains to be seen.
It's even in a forum like this where we were speaking about a lot of technical issues and we've done deep dives all this afternoon. We have had a number of questions on vaccines and vaccine hesitancy, which is on one hand, it's not surprising at all because we at Boom, we've been dealing with a lot of vaccine related misinformation and hesitancy. But on the other hand, it is also kind of shows that this is a question that is top of mind. And so maybe I'll just take a couple of questions and then we can move on to the next session, Doctor. So we have Sapna Lunawat saying trials were actually required first and then mass vaccination should have been carried out. And that's just a comment. We have other people coming in saying that, again, about the fourth wave and asking questions. They're asking questions about side effects of vaccination for children. And someone anonymous again asks, do you really think boosters should be administered? So I think I'll just reframe all these questions and just ask you what your view is specifically on boosters and vaccination for children.
Well, very simply, if you've been exposed to the disease and if you've been vaccinated, you will have immunity. That immunity will wane. That immunity has got two components: your ability to have antibodies against viral surface components, neutralizing antibodies, and you're developing what's called a T-cell response, which remembers your prior exposure. So even as antibodies wane, your native immunity wanes, you're going to have protection through other methods, which therefore mean that when you're exposed again, you're more likely to get mild to moderate symptoms. In that situation, boosters have to be calibrated in priority to a population where this waning of immunity is much more rapid. Those are older people and younger people with comorbidities. If vaccines are available, they are affordable, then you would expand it to a larger population. But that would be a prioritization steps. Now, for children, the answer is also similarly simple. What number of children, and we have getting that data globally, and we need to examine that nationally, when exposed to the currently spreading viral variants, do they show symptoms of significance which require immunization and which might result, if immunization is not done, in hospitalization? If that number of hospitalization is very low, that the current variants have very little danger to children, then again one has to take a priority of vaccination depending on that.
We'll leave it at that. Dr. Vijay Raghavan, thanks so much indeed for speaking with us and also taking those questions which seem to be popping up again and again. Again, no surprises there. Thanks so much.
Thank you very much. Excited. Thank you. Thank you.
Thank you.
Bye-bye.
Now we're excited to be presenting the next panel. I'll be moderating this discussion. It's on the mental health epidemic and the crisis at the workplace. So as we all know, the pandemic has profoundly altered our social and working environments completely across the globe, also in India. Of course, there have been so many things that have changed: social distancing policies, mandatory lockdowns, isolation periods, the anxiety really of getting sick and not knowing what's going to come next, along, of course, with suspension of productive activity, loss of income, fear of the future, and so on. So we're going to be talking about these issues and what can be done structurally to reimagine healthcare. Remember that, of course, is the rubric or the framework under which we're holding all of these conversations. And I'm going to be introducing this very exciting panel that we have right now. We have Dr. Soumitra Pathare, who's a consultant psychiatrist and director, Center for Mental Health Law and Policy. In the past, he has provided technical assistance to the Ministry of Health as well. There you can see it on your screens. And he's also helped in drafting India's new Mental Health Care Act 2017, which takes a rights-based approach to mental health care. He was also a member of the Mental Health Policy Group appointed by the Government of India to draft the first national mental health policy, which was released in October 2014. We also have with us Dr. Rajiv Mehta, who's been working as a senior consultant psychiatrist at Sir Gangaram Hospital, New Delhi. And in 2018, he became the vice chairperson there of the Institute of Psychiatry and Behavioral Sciences. Additionally, he's also working as an advisor for the Indian Council for Juvenile Research. Dr. Mehta is also a general secretary of the Indian Association of Private Psychiatry, which is of the Delhi chapter. And he's the author of the book, Speak to Anyone Easily. So we have two book authors. I'm going to be introducing the next person as well. And he's also authored multiple articles on various aspects of mental disorders in leading national magazines. And we have our third panelist. We have Ms. Kamna Chibber, who's the head of mental health at the Department of Mental Health and Behavioral Sciences, Fortis Healthcare in New Delhi. And she has a particular interest in working in the domain of relationships, trauma, abuse, and the impact of personality-related variables on mental health. Ms. Chibber works extensively with schools, corporate organizations, NGOs, and has a strong focus on generating awareness relating to mental health. Through her writing, blogs, and media interactions, she's also worked towards the larger goals of inclusiveness and removing of stigma and busting of misconceptions relating to mental health. As a coincidence, I have your book, Ms. Chibber, Age of Anxiety, I have, which you co-authored with Amrita Tripathi. Okay, so I'm going to start this conversation. One of the set of questions I'm going to ask you all is for your quick take on the issues of what has changed now in the post-pandemic world as we're entering the post-pandemic world. What was broken in the workplace specifically before? What changes were needed? And of course, the pandemic came along and shut us all out of the workplace. So now when we are going back, are we seeing those changes or are we headed towards business as usual? So I'm going to ask Dr. Pathare to start first, and then Dr. Mehta, and then Ms. Chibber.
Sorry about that. I had to unmute myself. Thanks, Venkatesh, for the question, and thanks for the invite from Boom Live for this talk. By the way, you got three authors. We just published a book on suicide prevention called Life Interrupted for the general public in terms of policy interventions. And one of my co-authors on that is Amrita Tripathi.
Yes, that's the fourth book in the series. Yes. Thanks for pointing it out. And that's a really nice coincidence. Yeah.
I'm sure my publishers will be very happy for me plugging these things in. You know how it goes. So anyway, to answer your question specifically, look, I think that we are, the pandemic has become a little bit of a watershed in many ways. Watershed for various reasons. Like before the pandemic, I suspect people thought, well, mental health problems happen to other people. They don't happen to me. Or they don't happen to people like me, or they don't happen to my family. And I think what the pandemic brought home to everyone was that, well, anyone can get it, including me and people like me and my family. And so suddenly we are hearing a lot of talk about mental health. Like before COVID, we wouldn't have had this panel, for example. So there is a lot more talk about mental health. But let's also be honest that what we've got is a whole bunch of problems, especially at workplace, which antedate and predate the pandemic. And going back, you're just going back to the same situation, in many ways, actually worse situation for many people. So they're not going to go away, and those problems continue to remain, and those problems have not been addressed by either by, government is a large employer. Don't forget, actually, the government is a very huge employer. So the workplace is government. Also remember that the defense forces of various kinds, the armed forces, police are another big employer. We always think of workplace as just being people in the private sector, but actually those are big employers. And the biggest group of people in the workplace in a way who get nothing and nobody talks about them is the informal workplace, the informal or even the non-formal workplaces where people are not organized, or what is called unorganized sector. So, these are all the areas where workplace issues remain. So I'm sure we'll be able to talk about it, but I just wanted to lay out, like, that's the canvas on which we are really talking about.
Yeah, it's a pretty huge canvas, come to think of it. We don't realize it. I'll come back to you, Doctor, for an understanding of, the basic questions I asked, also from a policy perspective. And when I say policy, I mean, obviously government policy, but also maybe corporate policy. But let me get a word in from Dr. Rajiv Mehta. Doctor, do you see any changes? Did you see a big change when it came to specifically maybe medication related to several mental health issues before the pandemic, during the pandemic, and now in the post-pandemic world?
Thank you, Venkatesh, for inviting us on this beautiful and wonderful topic. Yes, as Dr. Pathare has summarized very well, the acceptance is increasing. The stigma is decreasing. And among the workplace, which I also wish to include, will be the home front for the females, and in the school for the teachers as well as the students. So they may also be included in the policy things. But yes, coming to your specific question regarding medication, the use is definitely increasing. There are various factors to it. Number one, the incidence is increasing as such because of the various stressors. The stress is increasing. Because of the various reasons, the consequences in form of mental health issues is increasing, and the acceptance is increasing. Recognition is increasing. So in totality, the workload over the doctors who are handling the mental health issues, the mental health professionals, is increasing. In fact, some of the doctors, even the psychiatrists, have come under burnout with themselves also. So definitely the things are
interesting to see that trend. A little later in the conversation, Dr. Mehta, I'm going to ask you that question about, typically we always ask, right? Is there a danger of over medicating? Is there, are we emulating countries where the answer to everything is a medicine? So I'm going to ask you that loaded question a little later in this conversation.
I'm going to answer you that.
Yes. Ms. Chibber, I want to ask you, what do we mean really if someone comes to you and talks to you about, mental health at the workplace? Can we have clear distinctions? Is there such a thing as mental health at the workplace, mental health at home? Is there a useful distinction, or is it a distinction that kind of doesn't take into account a person's overall mental health?
I think we would all agree, all of us who are on the panel here today, that you can't segregate or compartmentalize mental health into different parts to say that, I can have good mental health at my home, but not good mental health at my workplace, because there will always be at the core of it all, or at the crux of it all, is the self of the individual. If the individual is having a challenge in managing their mental well-being, which is reflecting in the ways in which they're thinking, which is reflecting in the ways in which they are processing things, in their moods, in the kind of experiences they're having, in the kind of reactivity they're having, it's going to have a spillover effect into every aspect of their life. An individual may have a more difficult situation in a particular context, but that may not just remain stuck to that specific context, because when the person is getting impacted, the impact happens overall. So you can't segregate it and say that my workplace is not fine, so only here I will be having challenges in coping alone. It may start like that, but as soon as we recognize that there is a mental health related illness which has emerged for an individual, it will impact their functioning across all domains of their functionality. So social, occupational, their personal zones. Everywhere there will be an impact. There will be an impact on how they're functioning. There will be an impact in the ways they're being able to take care of their own selves. So it's going to be a more global aspect which would come into play in that context.
Okay, going forward, I'm going to ask you whether there's an increase in acceptance for people to talk about mental health at the workplace. I know on one-on-one sessions, there is a high acceptance, or maybe there may be a high acceptance among friends and family. Maybe I'm mistaken. That's a hypothesis I've made. But I also want to explore that topic. But Dr. Pathare, going back to really what you first pointed out, and I'm just thinking about the implications of what you said about the government being an employer. I mean, if we think about it, the government is probably the single largest employer in India, right? Especially if you now start counting state governments and city governments and so on and so forth. So when it comes to policy, I'm assuming that instead of dividing between, government and corporation and the workplace and dividing it that way, we think about the workplace for everyone. Is there an increased acceptance among in various governments that yes, we need to think more about mental health policies, we need to design better workplaces, and we also need to ensure that there is adequate budget? Do you see that kind of thing happening?
Well, unfortunately not. And I think that's what worries me. And I'll tell you, I think we should step back a little bit. What employers have done, and which I think in many ways the mental health professionals have been kind of complicit with, is that we made the mental health problem at the workplace an individual issue. Okay, so it's all the individual's problem. The individual needs help. And it's individual vulnerability. So, we made it like it's about the individual. It's about you need help, you are depressed. And what we've actually not done is to step back and say, hang on, what kind of environment are we living in? It's a little bit like, let's say you're living in a polluted environment and then everyone's getting chest problems. And you say, well, you got a problem, you're getting a chest problem. Well, there's pollution all around. What are you doing about that? So similarly, in the workplace with mental health issues, it's all become about individual vulnerabilities, about identifying the individual and helping the individual, with very little attention being paid to the kind of environment that is created by the employer, whoever that employer might be, in terms of their policies, in terms of resources, in terms of how people are treated, in terms of addressing the workplace toxicities that are created by the structure of the work itself. Now that is very conveniently avoided out, and it's always put out as an HR problem. An HR problem meaning, oh, it's a human resources, we have to do something for the people. But if you talk to the human resource, very often we get human resource people coming to us and saying, we want to do something at the workplace for our people. And you say, okay, we need to do a 360-degree analysis of it. It's not just individual vulnerabilities. It might have something to do with how your people who supervise your managers behave. It might have something to do with your policies. And then usually it's like, we don't really look into all of that. Can you not just provide some counseling? Can we do something which will improve wellness for them? So, I sometimes feel that employers are really, it's about lip sympathy to this whole process, to ensure that they are seen to be doing something, to have something to put into their annual reports, and to be seen as a positive employer, rather than actually get into it and address the issues that are there. I'm sorry if I sound negative, but that's the reality of what we come across in the workplace today.
No, you're drawing out a picture for us that is rooted in reality, as you said, and we're trying to build towards a better future, of course. So much appreciated. Dr. Mehta, that question that I flagged earlier, and I also want to add something else. There is increasing acceptance of the need for everybody needing mental health and good mental health, but mistrust remains, distrust remains. We do know at Boom Live that we do see a lot of misinformation related to mental health as well. And of course, you do have very valid criticisms of the medication aspect of treating people. For example, there was a question recently that the new DSM manual talks about a grief disorder. If you're in grief for more than 1 year, for example, it paves the way for maybe medicating it. So I'm asking you this question from that perspective. What would you have to say to that? Especially speaking about how we're going to build towards mental health at the workplace.
See, definitely there are many misinformations. I will say there are many myths. If we understand, every day some of the other of the new diseases are being discovered. Does that mean that they were not earlier? Definitely they were there earlier, but they were not detected because the things were not there, right? Now, if you see an example of eyeglasses, we know how much the deficiency in the vision is, but which chemical of the eye is deficient, we don't know, right? Now, try to understand. If there is a head injury, the behavior will change. If there is a stroke, the behavior will change. So from where the behavior is being controlled, it is being controlled by the brain. But as we cannot judge the eye chemical, we cannot judge the inside chemical. There is a limitation. But the behavior is being run by the chemicals: touch, pain, pressure, vibration, temperature, because different chemicals to the brain, right? So mental illnesses are similar to the physical illnesses. Insulin deficiency is diabetes, thyroxine deficiency is hypothyroid, serotonin or other chemical deficiencies is depression. So it's a misnomer to say that we are giving them medication. If we are just, if there is a calcium deficiency, we are giving calcium in a form of tablet or injection. So we are giving the bone vitamins. If there is an iron deficiency, we are giving the blood vitamins. If there is an insulin deficiency, we are giving the hormones. Similarly here, whether to call them as antidepressants or the brain supplements, it is how you say, perfectionist or sulky, crazy or genius, nadan ya badmash. So they are basically not the medication. They are basically just supplementing the deficiency of the brain, right? Now, if we take an example of diabetes or hypertension, lifestyle changes definitely helps in them. But still people keep on taking medication. Why? Because they will help in a pre-diabetic or a pre-hypertensive state or a preventive step. So similarly here, many things help in a milder form of the disease or in a preventive step. But once it has crossed the boundary of moderate to severe, then definitely we require the so-called antidepressants. In my language, they will be cognitive enhancers or brain supplements.
Got it.
And we don't have a choice. We don't have a choice either to pick the illness or the treatment. If we keep on waiting to work on ourselves, it takes such a long time. By that time, we lose so many things.
Got it. Got it. You know what you said has also sort of brought another question to my mind, and I'm going to ask that to Kamna actually. Kamna, there is this tendency to also say that everybody needs therapy, and there are some people who say that's not true. Everybody doesn't need therapy. No, so going forward in the workplace, and again, I'm deliberately focusing on the workplace, even though I know that it's kind of difficult to draw those distinctions. Do you see an increased kind of appetite to maybe corporations talking about ensuring that people get access to therapy? I can tell you from personal experience, I have seen that there's one company that I worked for in 2014. It's an American company, change.org. They had this practice of paying for a therapist if each employee wanted to go for therapy. So that was 2014. And I understand that this is kind of standard in many companies as well. So do you see anything like that? Maybe this is a question I should ask Dr. Pathare as well, but I'll start with you.
I think there are multiple aspects to this now. It's a fairly multidimensional question. Would everyone need therapy? I think it's a very generalized way to say that, everyone needs some sort of a therapist or a person to go and talk to. I think you need to split it up into two parts. Therapy is it's a technique, it's a treatment modality which is to be utilized for individuals who have a certain mental health related condition which requires that therapy. People who are talking about that every individual may need the therapist are referring to the fact that culturally, socially, we have become a society where our connections have diminished, or the nature of the connectedness that we have with people around us is not necessarily the best. So we don't have the spaces where we could go and have the conversations that we would like to. Which basically means that the friendships that we talk about, the relationships that we talk about, the nuclearization of families, which has happened over the years, and specifically more in the urban areas, has resulted in a situation where currently a lot of people struggle to find places where they could get the kind of support that they need, or where they could get the kind of inputs that they require to make decisions, make effective choices. And as a result, therapy or a therapist or a counselor becomes a person that they feel comfortable in going and talking to, because that becomes a space where they can confide, share, discuss, get some sort of a neutral understanding of what they could look at doing in that situation. But that would not mean that everyone needs a therapist. What we do need is greater connectedness in our society. We need to go back to our roots, the culture that we come from. We need to find ways to start getting to know our neighbors, build better relationships within the communities we are part of, so that this experience of loneliness, which has become such a pervasive part or experience for a lot of people, gets taken care of. So I think that's one part that we need to try and understand here. The second aspect I do feel is that when we are talking about workplaces, our workplaces talking about providing mental health support, yes, but like Dr. Pathare was mentioning, which Dr. Mehta was also talking about, workplaces are of so many diverse types. Certain workplaces have the resources, they're willing to invest in it, and it's an investment. And research has very clearly pointed out, and this is a very old statistic which is there, for every dollar that you spend on mental health, you get returns which are about $4 worth. So yes, it is an investment that is worth making and which organizations should consider. Would every organization have that bandwidth to be able to provide that platform to all of its employees? Not necessarily. But the other aspect also is our country, and we're specifically talking about India here, does not necessarily have those many experts. We have a significant dearth of experts available within our country who would be able to provide those kind of effective services as well. So what is also probably required and needs to be thought about is how do we probably start training or providing ways in which psychological first aid can become an integral part of the skill building that happens within workspaces, which would allow people to provide the right kind of support within the system itself. And this has to be a top-down approach. Like Dr. Pathare was saying, that it's become about the individual. The individual needs to work on themselves. We need to start changing that approach that has come about, and we need to start emphasizing that it has to be top-down, it needs to be within the system, it needs to be integral to the organization to talk about mental health, to invest in mental health, to make it, to create awareness around it, to initiate ways in which conversations can happen, to provide psychological first aid, and to also, of course, look at collaborations with external organizations who provide such services. We provide such services as well as at Otis, but that will not necessarily be the only solution. It has to be a multi-layered solution, which I believe, and I'm sure Dr. Pathare would be able to also, I would add so much more to this I was sharing about.
I just want to add to our panelists, if you feel like jumping in, feel free to jump in. Let it be a free-flowing conversation. So if you want to add to what she's saying, please go ahead. Otherwise, I have two areas I want to focus on.
Let me jump in since you made the offer, because I've been kind of itching to jump in for a while. Okay, I think it's much more complex than what it is. Okay, so to your original question was, is there too much of medication and is there too much of therapy? Which is really what you're going on. And the answer to that is complex. At one level, yes, there is too much of medication and there is too much of therapy. At the same time, equally, there is a whole bunch of people who do not receive the treatment they need. Either it is medication or therapy. I mean, we know the National Mental Health Survey, for example, showed that 90% of people in this country with a mental health problem don't receive any treatment at all. So, you have, it's the same thing that you have with, like, say, the malnutrition and the obesity issue. We have a problem with malnutrition and stunting, and we equally have a problem with obesity. Too much of it and too little of it coexisting at the same time. And I think that is really what happens with mental health. There is too much of it and coexisting with too little. The other issue is that also mental health problems are complex in the sense that they are not necessarily like, say, a physical health problem in some ways, because so many years, like the NIMH had a whole decade of brain and spent some $5 billion trying to find out the biological substrates of mental illness, and haven't actually managed to find anything at all. In fact, even the researchers and psychiatrists in US are very critical of the fact that money spent has not actually delivered anything. So it's complex. It's not just biological, and very often the social factors tend to be far more prominent. And I'll give you an example of it. During the pandemic, for example, in countries like India and many of the low and middle income countries, even in South Asia, have seen suicides go up dramatically. Okay, like our suicides in 2020 went up by 10%, which is a huge jump because they were like at 1% up and down here and there. And same thing you notice in Africa as well as in Southeast Asia. On the other hand, if you look at countries in the West, and especially North America and Australia, suicides have not increased at all during the pandemic. And the big difference, if you might want to look at it, was the provision of income support, for example. So, there's evidence from Brazil, for example, that if you provide good quality income support, they did a study with cash transfers with 100 million people over 15 years, found that suicides among people who received a cash transfer was down by 60%. Now, the fact is that no mental health interventions reduce suicides by 60%, but a cash transfer does. So my point is that, yes, people need mental health support. People need individual support. They need the counseling. They will need medications at times. But let us not forget that it happens in the context of a larger social thing, which if you do not address, then those individual supports are not going to work. It's really, and that's why I said it's complex. It's not an either or issue. It's not about, oh, should we do this or should we do that kind of a thing.
Yes, I'm glad you made that distinction between too much and too little, and I want to focus now on the too little aspect. And by the way, if anyone has any doubts about my own perspective, I get health. I go for therapy, so I'm a big believer in help and support in the mental space. Mental space is such a weird word, no? Anyway, the point is, the question there are two other things I want to ask, which is the insurance sector. One can get medical insurance for a certain set of ailments, but I don't know what the scene is in India, in corporate India, and of course in government, in governments, whether that kind of policy is in place. So, Dr. Pathare, I want to start with you again in this, which is, what is the policy scene here? And of course, I do want to point out that 90% of India's economy is informal. So when we're talking about corporations, we're really not talking about the majority of India, but I'm asking you that question.
Right. Well, I'm glad you asked that question. So what does the law state? The law is very clear that there should be parity for insurance. Okay, parity meaning if you're providing insurance coverage for certain health conditions under certain conditions, and the same conditions should apply for mental health too. So, for example, if you said, if you have diabetes, we will allow you treatment for diabetes, but only after 4 years because you have pre-existing diabetes, then you should allow for mental health on the same condition. So the idea of parity is that you treat both physical health problems and mental health problems on an equal basis. Now, although the law came in 2017, the IRDA has really not done enough. So they keep on saying we've sent out a circular, we've got insurance companies to respond. The fact of the matter is that most of the insurance companies which have responded have either been because there have been 3 or 4 insurance companies which have now removed the mental health exclusion, for example, out of their policies. So you can get mental health care. But a lot of it has happened because of action in the courts. People have gone to court and said, listen, my policy still has this exclusion. And, the Delhi High Court had a very good judgment last year, which said, as of 2018, any health policy, even if it had an exclusion, because the exclusion is against the law, it would not hold water. So, the insurance company was making an argument, well, you signed the policy, it had an exclusion, you should have seen it, kind of stuff. And the government said, well, you can't sign a contract which is patently illegal. You can't have conditions in a contract which by the law of the land can't happen. So, in many ways, effectively what that judgment says is that anyone who's got a health insurance is covered for mental health. Now, the problem you have with mental health is different slightly. What happens in India is that health insurance is largely catastrophic health insurance. It covers for inpatient admission, really. Very few health insurance policies will cover outpatient treatment, although there are a few, okay? Now, the point is that what happens with mental health is most of the treatment is outpatient treatment and not inpatient treatment. Right. So, your health insurance policy might cover mental health, but since 90% of the people take outpatient treatment, it's not getting covered. So that's another issue. In fact, I would say that corporates have been far better, okay? Even before the law came in, the corporates would negotiate with insurance companies and remove a lot of these exclusions, So, for example, corporates, when they got group insurance policies, removed, for example, the pregnancy exclusion. They would get the mental health exclusion removed. So they would get that removed. So for many people who work in private corporate sector with large group insurances, they've always had mental health cover, and some of them even have outpatient mental health cover. So what I would, so it's that. And in the public sector, the answer is very simple. Ayushman Bharat actually covers, there are 13 packages of care for mental illness, which are covered in government sector. They don't cover it in the private sector though. They say you have to go to the government hospital and cover it. But they cover a large chunk of the inpatient admission cost that will come in. So, in some sense, we are having, it's patchy, it's not complete, but it does exist. Now, if somebody wants to really look up, if you want to buy a health insurance policy, and look up and say, look, what is my health insurance policy cover, or is it good enough for mental health or not? You can go to our website. We've created a searchable database of some 500 health policies which are there. And if you put in the name of your policy, it will show you what mental health coverage it provides, and also show you which are the best insurance policies at the moment for mental health coverage. So, you can do a search and find it out. I think people will have to make that effort.
Yeah, if you can be kind enough to write in the URL,
sure.
While I go to the others. Dr. Mehta, I mean, I don't know if any of you want to say anything on the insurance aspect,
right.
But I do have another, sorry.
I will just, basically, what Dr. Pathare is saying is very right. The problem comes at the point of implementation also. Right now, in the previous month, I had 2 patients. One, the insurance doctor will not know what is happening to the mental health of the person. They will ask idiotic questions, multiple questions, same questions framed a time and again, or in different language, so that they can drop the insurance, so that they should not pay. So in that way, the doctor who's treating becomes a doctor, as well as he has to see the administrative part also. So the doctor themselves start saying, boss, medical insurance may not get covered. Because the insurance companies, in order to deny the insurance, will ask multiple questions and the same questions time and again. While on the other hand, there are many corporates, like our hospital is associated with Maruti, they cover the mental health easily. So there is a concept in the insurance sector how to deny this. That is the part which has to be taken care of.
Yeah,
and that denial is basically the lack of investigations in the mental health sector. What I can see, because you cannot prove it, you have to come and see it. They won't come and see it in the hospital, so you cannot prove it with the test. So that is another, because the people tend to misutilize such things. So it is a biased role. That
a huge area of concern. I'm glad you brought that up. I'm going to shift to another topic, and I also want to be mindful of everyone's time. It's 5 p.m. So far, we've spoken about a number of interesting. We've gone down many different rabbit holes, as they say, and there are a couple remaining. We're going to stop this discussion and go to the keynote to end the entire day at 5:15. We're going to go to the keynote. So we have about 14 minutes, and this is a reminder for the audience. There is no such thing as a bad question. Please write in with your questions before I ask anything. And I think, Dr. Mehta, you want to say something?
And I must appreciate that this is the one of the first kind which is everything is on time.
Thank you so much. Yes, all our guests were on time, and the conversation went ahead smoothly. Thank you so much. So I want to ask the next question, which is, okay, we are doing this conference in English. We have 22 official languages and hundreds of unofficial languages. How are we going to break the language barrier in India? And so is there any capacity? Is the capacity very limited? Do we have qualified enough people to talk in multiple languages, whether it is Hindi or Marathi or Tamil or Telugu, Kannada, Bengali, Assamese, it just goes on and on, right? So how do we break the language barrier in India when it comes to mental health? I'm assuming that a number of people, and I do know that, words like anxiety and depression and whatever else, there are multiple words people use to indicate that same feeling, right? And we have lists of those words, but do people have a language to express their feelings? And starting from there all the way to, is there enough capacity in the system to even begin to start talking about mental health care in multiple languages? And is there a capacity within organizations, governments, public health, public sector, and so on? So I want to get all of your comments on this. I want to start with Ms. Chibber.
If I start with the first part of the question, that would everyone have the right vocabulary to be able to communicate what they're experiencing? I think people do have a certain language that they have available to themselves, and that's their colloquial way of expressing whatever it is that they're going through. Would it necessarily resonate with every type of expert? Not necessarily, and which is what makes it very important that we need to have experts available who can be able to communicate with people in their own language. That's a given. We all resonate with that aspect. There are, of course, people who are trained to use their own language to be able to provide the kind of treatments that are required by individuals. And case in example is that we run a 24-hour helpline, which is available in 14 national languages, which is run by experts who are trained in mental health, in psychology, in psychotherapy, in psychiatry, and they are providing those services. I think what we do need to start understanding is that despite some of these availabilities, it's still that we have a dearth of experts, and that is not something which is getting compensated for today or tomorrow. There's a huge gap in the services that we do require. Like Dr. Pathare also pointed out, 90% of the people who do require mental health services do not receive those services as well. The kind of gaps we are looking at are enormous. And while we do recognize that services need to be available in the language of choice of the individual, I think we have a large way ahead of us. And maybe some of the things which are going to be helpful is, for instance, digitalization. The whole pandemic, the last 2 years, what we have realized is that digital platforms can be utilized, something which was talked about, which has actually gotten implemented. People are being able to utilize experts' help and intervention from very far off places. That's something which is happening. We are being able to make some inroads into that space. We have to look at how do we create programs which could train other experts who are working within the field where, say, for instance, a psychiatrist or a psychologist may not be available. How do we do that? That is going to be of critical importance. Can we look at collaborating with Anganwadi workers? Can we look at collaborating with ASHA workers, providing training systems? I think, in fact, Dr. Pathare, their organization does extensive work within grassroots, in the grassroots space, and they go into communities and they do a lot of training. So those are the kind of things that we do need to also push for. And a lot of those programs are run in local languages, because we know you can't build a connectedness within the community and you can't help the people unless you're going to be talking to them and communicating them in ways that they will understand and you will understand what the experience is for them.
Understood. Dr. Mehta and then Dr. Pathare.
Right. As Ms. Chibber said, basically, definitely there is a large lacuna. On the other hand, we are getting cosmopolitan and the language barrier is decreasing slowly and slowly. Hindi and English is being spoken by various and multiple persons. It is only in the rural context, which are too much inside, where the language barrier is of much importance. So while there are psychiatrists and psychologists at every level, so if they are working nearby, then the language, if they are working in their own state, then the language barrier will cease to exist slowly and slowly. But definitely the workforce is very, very deficient.
Okay. Dr. Pathare?
Yeah. So look, I mean, it depends on what you mean by language. As Dr. Rajiv Mehta said, Hindi, English, people talk the language. I think that is not really the issue. And do people have a language for their distress? I think they do have a language for distress. People are able to express their distress in many languages. But if you took language in a much more broader sense, then do people talk the language of the professionals? They don't. And do the professionals talk the language of the people? Then they don't. And I'll tell you what I mean by that is that conceptually, people in our communities, and not just our community, across the world, we've seen conceptually, people will not classify their problems as, oh, I've got depression kind of, and I tick these 5 criteria that the DSM has got. That's not how they think of depression, or they don't have neat categories of depression or anxiety. Oh, I have anxiety, I don't have depression. It's not that. So increasingly, a lot of people across the world have started saying that, look, let's take a trans-diagnostic approach to this whole thing. Let's not get into saying, oh, have you got depression, or have you got a mixed anxiety, or have you got anxiety? We know there is a cluster of these symptoms which go together, and that's how people express their distress. So people do express their distress. They do have a language. They may not have the jargon that professionals have for it. And the professionals sometimes are unable to understand distress unless it can fit into their pigeonholes of what diagnostic categories they've made. I mean, don't forget, at the end of the day, the DSM diagnosis is, or I always call the DSM diagnosis as a camel is a horse designed by a committee. Basically, they keep on changing the diagnostic criteria every few years, because the reality is, if your diagnostic criteria do keep on changing, is because we really don't know enough about what are these categories. So there are broad syndromes that we should be talking about, and addressing distress for people is what we should be talking about. And that language actually exists very well, even with the non-experts. You might be actually very good at understanding and expressing and working with somebody who is experiencing mental distress. And paradoxically, that might be also because you're not a trained mental health professional, because you're not kind of then stuck into the jargon of mental health that professionals get stuck into. So, we need to really get past that kind of divide of unless you have a particular diagnosis, I can help you. Distress is distress, and people need help, and we should be providing that help. And as Kamna said, that we are never going to have enough experts to help everybody. And so what we've been doing very often is actually working with community leaders to try and provide training and support. And we have enough research evidence to say that what are called as lay workers, they are volunteers or even sometimes paid people. And many of our volunteers are hardly educated up to the 10th grade of school. They are very good. They're equally good at times for mild, moderate symptoms, as good as any expert would be, with very little amount of training in that sense. So, I think we should really, the real challenge is at the bottom of the pyramid, so as to speak. That's where the challenge is. And there's no way you're going to have, look, America has the largest number of mental health professionals in the world. About 20% of the world's psychiatrists, or 40% of the world's psychiatrists practice in America, which has a 4% of the world's population. And yet the US has a treatment gap of about 20 to 25%, which means 20 to 25% of people do not receive the treatment that they should receive. So clearly, just increasing the number of professionals is not the solution to addressing the whole issue. You need to broad base how we provide help, where we provide help, who is provided with help, and what help is being provided for.
Yeah, it reminds me of what Ms. Chibber said about a little while earlier about, we're living in a world where the nuclear family has really meant that we've lost contact with community and other infrastructure, so to speak, that can help us. So we've spoken about the bottom pyramid, and I suppose there's no need to talk about the top of the pyramid, because they're getting all the help that they want. And we started with mental health in the workplace. So let's close on that note. There are 4 minutes remaining. So can I just get sort of concluding remarks on where you believe this is going to go, and where trends should go in the workplace? So I'm going to start with Dr. Rajiv Mehta, and then come to you, Dr. Pathare, and then end with you, Ms. Chibber.
See, basically, slowly and slowly, the acceptance is going to come over. As we are getting westernized, so similar Western trends are going to come over, and the acceptance will increase, and slowly, the people are going to accept the therapy part, the label part, the therapy part, and the medication part. And the future seems to be bright in that manner, but a shadower in a manner of that increasing mental health issues will be there.
Got it. Dr. Pathare?
where we should go, I think, really is for all employers. I mean, since we are talking about workplace, is for all employers to actually start taking a more broad-based perspective about mental health issues in the workplace, and not purely see it as a productivity tool or as a purely a welfare tool. While it might be a productivity tool and a welfare tool, it is also about creating better, healthier working spaces for everybody. So that's where it should go. Where I'm worried it'll end up going is that we'll take a very reductionist approach to it and say, well, you've been provided with either with a prescription or with a therapy kind of, here you can go and have this therapy and it's paid for, while completely ignoring the broader context in which things are happening.
Okay. Ms. Chibar?
I absolutely resonate with what Dr. Mehta, Dr. Pathare pointed out. And I truly believe that what we do need is greater awareness, bring in acceptance, create access. And like Dr. Pathare was pointing out, it should not be about what an individual can go and do for their own selves. Start looking at the system, start looking at the organization, and what is the kind of cultural environment that you can create over there? What are the kind of initiatives that you can bring in, the right kind of intent to create an environment which facilitates, maintains people's mental well-being? I think that's of crucial importance, and which will in any case automatically reduce the pressure on the mental health delivery system as well, automatically.
Okay, that's a great note to conclude things, but I've noted with interest that the Q&A box was filling up in earlier conversations. The number of participants hasn't really changed. So people clearly do not want to ask questions. So I'm going to ask a question on everybody's behalf. Okay, and so I'm going to ask you all that question, maybe one or two questions. Maybe we can sneak in a couple of minutes before we have Dr. Nachiket Moore delivering his keynote. So let's say I want some kind of help. Who do I go to? Should I go to a family doctor? Should I go to I don't know if there's any such thing as a family doctor anyway. Should I go to the nearest doctor and ask for help? Where does the mental health journey begin? And reverse order, I'll start with Ms. Chibar and then Dr. Pathare and Dr. Mehta.
One thing that we advocate at least is usually go to any qualified person, any doctor who you know would have some sort of an understanding, talk to them. They will be able to direct you to the right expert. A lot of people get confused between, should I go to a psychologist? Should I go to a psychiatrist? If you're experiencing distress, if there are certain things which have been troubling you, if you see that persistently your productivity or functioning is getting impaired, reach any doctor that you do need. They will direct you to the right person. Any person who's a trained doctor will have the expertise to be able to guide you into the right space. That's how I would suggest people should approach it.
Okay. I'll add another question to it, which is, okay, but we go to the nearest qualified person. But what if I don't know? Is it easy for family members, for example? Is it ethical for a family member to say to another family member, you should go and see this person? How does a family member who wants mental health intervention for another family member, how do they tackle this question? Maybe I can get Dr. Mehta and Dr. Pathare and whoever wants to jump in, basically.
Yeah, I mean, look, it's complicated, Venkatesh. First of all, when we say mental health problems, we are not talking about one set of problems. It's not like we're talking about just diabetes or just tuberculosis. You're talking about a whole host of conditions which might range from some minimal anxiety to somebody having a much more severe problem like schizophrenia or a bipolar illness. Okay, so clearly there is a whole range of problems, and what help anyone will need will vary according to which problem you are talking about. But my usual answer to anyone who says, I think I need help, my answer to them is usually along these lines, which is, let's say you got up one morning and you had a little bit of a flu and a runny nose. What would you do first? The first thing you'd probably do is just do some home remedies, isn't it? You're not going to just rush. You're not going to get up and put on your coat and get into the car and say, let me go and find a doctor. I've got a cold. I've got a runny nose. You're not going to do that. You're going to do some home remedies. You're going to do something to help yourself. You'll try for 3 or 4 days. And if that runny nose still doesn't go away, you might ask some friends or colleagues or something, listen, it's just not going. Do you think? And then they'll suggest some other remedies which you might try for another 3-4 days. At the end of which somebody will say, listen, this is not getting better. You better go and see the doctor, okay? And you'll go and see your family doctor or a GP nearby who might say, oh, take these pills for 3-4 days. And if it doesn't get better, then you go back after 4 days and say, listen, I'm not better at all. Maybe at that point, he will say, okay, you know what? I'm going to ask you to go and see the specialist at the hospital, the chest specialist, because your cough is not going away. It's now nearly a month or 15 days or 20 days. And that's the process in which people receive help for physical health problems. And I think almost a similar process should be followed for mental health issues. You know, you don't want everyone rushing off to see a psychiatrist or a psychologist when they've got an equivalent of a cough and a cold, which is going to get better in 4 days. You don't want to do that. So you want to actually have this very stepped care kind of an approach to the whole thing, so that people move up a step depending on how they're responding. And so that's what my advice would be to anyone like you, and I'm assuming anyone like you, meaning people who come from a certain class and of society where you have access to lots of things like internet, you have access to friends, you have a social network, you understand mental health to some extent, that kind of stuff. So I think you need a range of things. You need to start with the easiest stuff, which is self-help and some home remedies for your mental health issues, to asking your friends to help you, to asking your local doctor, and then maybe seeing a specialist.
Okay. We've just had 2 questions come in while you were all speaking, and I've got permission to maybe ask a couple of more questions, assuming, of course, that it's okay with you all. So, Ms. Chibber, at what point do you know if one should go and get therapy? Question by anonymous attendee, and then I'll ask the next question to Dr. Mehta. Actually, you know what? Before you answer that, Ms. Chibber, I want to prime Dr. Mehta for this question, which is Ipsita Parida is asking, what is being done on the employer front and encouraging more employer assistance programs like they have in the US, and ensuring that employees feel safe and they are able to access care more readily. So, Dr. Mehta, if you think about,
this question will be better answered by Dr. Pathare.
Okay, I will
answer your previous question. I can answer your previous question, how to make the other person go to a doctor.
Please do.
Your
go
family
for it.
member go to a doctor.
Answer that question, then I'll go to Ms. Chibber. Yeah.
See, basically, initially you talk to that person that your behavior is changing. Previously, you were like that. Now you are like that. Get his resonance. Get his yes. And when there is a yes, let's talk to somebody who's well aware of this field. We may not just start the treatment, but let's discuss it. And once he is ready to go, then everything will settle. Number 1. Number 2, definitely the family physician is one of the best person to talk to initially. But when you go to the family physician, generally what happens in India is they will write the medication. They will not discuss about the diagnosis and other things. And most of the psychiatric diseases are being treated by the other specialists in India. So when you go to any specialist, do ask about the diagnosis. What are the diagnoses he's thinking of or making of, and what is the specialist?
Got it. The at what point do we know one should get therapy, Ms. Chibber?
Right.
Individuals, like Dr. Pathare was also saying, that distress at the end of the day is for us very, very indicative of whether an individual needs to seek any support or help. If you don't have individuals available around you, distress is mounting, you're experiencing that your functioning is getting compromised across the different domains of your life. It's affecting your moods, it's affecting your thought process, it's affecting your responses to situations, and you're struggling to be able to cope with the situations. It would be indicative of seeking help, support. If these are situations where you need to make active decisions and choices, therapy could certainly be helpful. And you need to figure out, and a lot of times, even within, when we're looking at mental health related illnesses, when an individual is taking psychiatric treatment as well, as an adjunct, psychotherapy is also indicated across a host of conditions, and that is automatically recommended by the treating doctor as well. So those would be the indicators broadly.
Definitely.
And Dr. Mehta, I think I interrupted you.
In other words, basically, when there is a behavior change and when it is continuous and it starts impacting your social and occupational life, then it is the time to seek a help or a therapy. number one. And number two, the research says definitely what Dr. Chibber is saying, psychotherapy plus pharmacotherapy, both going together has the best result.
Understood. I think, Dr. Pathare, I'm going to ask you if you don't mind answering that question by typing it out. It's in the Q&A box by Ipsita Parida, because I want to be respectful of everyone's time, and we have our keynote speaker, Dr. Nachiket More, with us. So on that note, I'm going to thank you all. It's been a tremendously insightful and exciting discussion, and it's only the beginning, as we can see that we are living in a post-pandemic world, and hopefully there'll be more and more acceptance and at faster rates and faster speeds going forward. Thank you all very much.
A very well moderated session.
Thank you.
Thank you, Venkatesh. Thank you for asking.
Thank you so much. Thank
Bye-bye.
you. Right. So we now move on to the final keynote address of the afternoon. We have with us Dr. Nachiket More. He's there. That's the keynote. It's on the future of primary healthcare. Dr. More is trained as an economist. His current work is principally focused on the design of national and regional health systems. He's a visiting scientist at the Banyan Academy of Leadership in Mental Health and a senior research fellow at the Center for Information Technology and Public Policy at IIT Bangalore. IIT Bangalore, that seems a bit strange. It's probably IIIT Bangalore, but Dr. More, I'll let you correct me. He's also a commissioner on the Lancet Commission on Reimagining India's Health System. The floor is yours.
Thank you very much for inviting me. I will switch on my video in a little while. Can you all hear me?
Yes, we can hear you.
Okay, I'm at a government office. I'm still not done, so I'm talking from there. So thank you very much for inviting me. It is indeed IIIT Bangalore. I am a senior research associate there. They have a center called the Center for Information Technology and Public Policy, and I'm a senior research fellow there. In addition to the role I play at the Banyan Academy of Leadership in Mental Health. Now, the topic I've been given is somewhat broad. It's what the future of primary care might be like, and obviously, it's an area in which there are a number of opinions, number of thoughts about where the future might be headed, and what we might do differently in terms of primary care as we imagine the future. Let's take a 10-year horizon, for example, and think through what we might do with that particular perspective. I want to take a position that has a kind of two choices available to us, or maybe three. The one choice is what we have today, which is the government runs it in a somewhat very light touch manner as they go forward with the sub-center, the primary care center, the ASHA worker, and providing basic maternal and child health services to a vast population. My own hope is that by the time we end up in 2030, this is not the health system in terms of primary care that we would have, that we would have moved beyond that to something that is far more organized and far clearer, in terms of comprehensive, in terms of high quality that is available. So if we put that aside for a minute and we think about, okay, what would be the other two ideas that are there? One idea that we encounter is what I would say, the telemedicine idea, which is people with smart devices operating from remote areas, engaging with professionals, doctors, specialists, etc., to try and figure out what is in their best interest. And this is something that a number of people have been talking about as perhaps the future of healthcare. I think this perspective, despite its popularity, misses an important dimension of healthcare, which is that a core driver of the challenges that we face in healthcare relates to our own behavior, relates to the fact that it's not as if where access is high, we have good quality primary care, or that health-seeking behavior is that good. The problem often is that you have high quality primary care, but many of us don't actually seek the primary care that we need. Second, and that's another issue that is important when we think about primary care, is that primary care is more than a reduced version of hospital care, which is, when I'm feeling sick, I go to the doctor and the doctor takes care of me. Primary is simpler, hospital is more complex. Primary care is much more. If you look at the work of Barbara Starfield, for example, it has a number of dimensions. For example, comprehensiveness, empanelment, ensuring that you are doing care coordination. Many of these aspects, this framework of telemedicine outreach does not actually fulfill. And on top of that, we know that technology is proceeding fairly rapidly. And we are starting to see a lot of movement, use of, CRISPR, for example, as a technology that can do diagnostics at the front end. These are not things that can be available in a pure telemedicine model. So question is, if we don't like that very skeletal government view, if we don't like the government narrow, very skeletal perspective, we think telemedicine perhaps is not the right answer. Then the question is, what is the right answer? Where do we go? The view I take is that good primary care is actually very much within our reach. Today as well as going forward, we have to rethink a little bit what primary care means and what can we achieve with it, and what the overall set of examples are from around the world as well as in India that we can turn to convert that into something that is away from imagination to something that is real. One key aspect of primary care that I want to point out is that unlike hospital care or what I would call tertiary care, the reality in primary care is that patients come with symptoms. They come not with a situation in which you have clarity of what the disease is, and the variety of conditions that patients come with is actually pretty large. It's hard to say from the symptoms what the final answers would be. My sense is that some of this will go on changing as we go forward, and our understanding of conditions, our understanding of what the challenges are, will become more and more severe, more and more clear, and our approaches to deal with them will become sharper and sharper. The question is, how does one execute this in primary care? The older model, in which you had a trained individual that received 5 years of training, 7 years of training, and was responsible for assessing all of this and making a decision, the person we call the doctor. My own sense is this is not going to be sufficient for what is needed as we go forward. One piece of evidence, for example, is that if I look at the UK GP, who's perhaps the most highly trained general practitioner and physician in the world, their cancer referral rates are almost 70% lower than their counterparts in other countries, and 70% lower than they should be. Because the reality is that cancer diagnosis in a primary care setting needs a lot of assistance and a lot of support, which a general approach towards a black box screening is not going to supply. Now, we might think, okay, well, if that is indeed going to be the reality, then how are we going to respond to it? To me, the best way to respond to it is to respond to it via a much more protocolized technology-assisted mechanism, working through individuals that are at the front lines, are working in primary care settings, but are not necessarily trained in that overall black box perspective. There are people that are, just 1 second, please hold on. Hello?
Please continue, Doctor.
So with these approaches, with protocols, with these technologies, and they're already real. If I look at, for example, a provider like Babylon, which the Gates Foundation worked with in Rwanda, and now runs a very successful primary care operation in the UK called GP at Hand. If you look at the kind of technology that powers their work, even today, it has the ability to solve problems in ways that are much more rule-based, much more technology-driven than based on some kind of training. So the vision I have is a primary care which is much more protocolized, works in a much more rule-based manner, and allows us then to deploy personnel that are not necessarily MD doctors or even nurses. If I look at, for example, a country, a region like Alaska, you see the use of undergraduates who are able to be used to figure out what is the comprehensive primary care that can be done. And this is an ability that we have to use the vast workforce and human resources that we have available to us and to deploy them to provide the best quality primary care that we can imagine. And there are many other aspects of this that will then go along with it. Many new technologies are becoming cheaper and cheaper. One specific example I want to give you is that a point-of-care ultrasound, which is the ability to use AI-assisted, augmented reality, assisted ultrasound capabilities that can be deployed by a lay health worker to do some fairly sophisticated diagnosis without having access to a screen, so you don't attract the penal provisions of the PCP and DT Act, for example. So, these are a number of ways in which that front line will change quite dramatically. So let me stop here for a minute to see if I'm making any sense at all and what people feel are the reactions to this.
Yeah, it's a good time for us to bring in questions if there are any questions at this stage for what Dr. Moore has been speaking about. Dr. Moore, let me ask a question on behalf of the others, which is, you did mention AI fuel technologies and also AR technologies. Do you see technology as kind of something that definitely we obviously will not be able to sidestep, and it's going to help us? But do you see, as we've seen in the field of misinformation and information, it brings with it greater problems as well? Do you see that kind of thing happening in the future when it comes to deploying technology in the future of primary healthcare?
Now, clearly, if we abdicate responsibility, if we start to take the view that technology is the God, it will figure out what to do, that perhaps is a possibility. But what I'm advocating is a notion in which technology is used to enhance human capacity, so that frontline health worker who is a BSc biology operates at a level that is significantly above what she could have done or what anybody could have done in the absence of technology. Now, clearly, technology is valuable. So the human being will have to learn. Technology will have to have fail-safes to make sure that if there is something that it doesn't understand, it triggers a referral, it triggers a reversion back to the trained specialist that we don't have today. But if we manage that well, I really think, we will go from a situation because if you see what a lot of people are doing today in medical technology, if I look at pharmaceuticals, if I look at telemedicine, they've taken routine offline processes and simply made them online. That is not technology, or that is technology, but it's really the most reduced form of that benefit. So, I don't see the downside of as much of a concern, relative to what we are doing today in the manual space.
Okay, that makes a lot of sense. One more question for you, Dr. Moore, and we can close. So when we come to reimagining the state of health in India and the future of healthcare in India, would you advocate for a radical approach or an incremental approach? A radical approach would be to really rethink everything. Do you think that we have the capacity to do that, or whether it's even wise to do that? Or would you say an incremental approach is more is what we need?
See, there are some aspects of this that will just have to change. There is no, if we want a good health system, we can't, take the view that we can somehow manage. One, for example, the very use of technology. Today, I go to the best of hospitals, I go to the best of doctors, they are stuck with filling up paper forms, right? If you go anywhere else in the world or any good health system, these have just disappeared, right? I mean, it's really quite amazing to see the distance now between the modern practice of medicine and what is going on in our clinics and hospitals. So I don't see incrementality there. I think somewhere that movement will have to happen. Second, and this is a deeper question beyond what we are discussing here, is that of financing. Nobody has built a good health system without government stepping up with at least 70 to 75% of the financing needed. It need not provide the healthcare. We are in India obsessed with who provides it. Government can do a terrific job. There are countries like Turkey and Thailand that have done a good job with largely government provision. But there are many other countries that have done a terrific job, UK being a developed country example, in which all of primary care is private sector driven. But financing, there has been literally no exceptions. Everybody has gone with government financing doing 70 to 75%. So I think these would be big changes. I don't think we can dance around these two realities.
Yeah, got it. The reason I asked that question, Dr. Moore, was because, post-pandemic world, and we're at a point where perhaps we can take these radical steps. On that note, thank you so much indeed for joining us. And I think your audio also became pretty clear, so we were able to hear what you were saying. So thanks very much indeed. And for those of you who want to catch the points that he made, and indeed catch the points all the guests made, we have a recording available on YouTube. You can catch it. And on that note, we'll thank everyone. We found these discussions very, very interesting and insightful. And we thank all the panelists and the delegates, all the participants for joining us. Thank you for the questions as well. It's been a wonderful virtual audience, and you've lasted all this while, which is fantastic. This is an event which has been brought to you by the Ananta Center and Boom Live. Our knowledge partners are Swasth Alliance and India Spend. Thank you to Dr. Ajay Nair as well of Swasth Alliance. And we'd love to hear from you, your views, your feedback on this event. And once again, thanks so much on behalf of the Ananta Center and Boom. This is me, HR Venkatesh, signing off. Have a great evening and see you next time.